Yoshlarimiz, poytaxtimiz mehmonlari, qolaversa tibbiyotimizning mana shunday vakillari. Barchangizni bugun mana shu markazda ko'rib turganimizdan bag'oyatda mamnunmiz. Bolalarda onkologik va onkohematologik kasalliklar diagnostikasining yangi ufqlari ilmiy amaliy konferensiyasiga xush kelibsiz. Доброе утро, дорогие друзья, уважаемые.
Dear ladies and gentlemen, dear guests, we are very glad to meet you in this beautiful, comfortable center. Welcome to Scientific and Practical Conference. The topic is New Horizons in the Diagnosis of Oncological and Oncohematological Diseases in Children.
Sog'liqni saqlash onkologik kasalliklarni oldini olish bilan bog'liq bo'lgan muhim ma'ruzalarni ham tinglashga muvaffaq bo'lasiz. Va ayni damda barchangizni e'tiboringizni konferensiyaning ochilish marosimidagi so'zga chiquvchilarni taklif qilishdan avval e'tiboringizni monitorga qaratmoqchiman. Итак, дорогие друзья.
So, dear friends, right now, let us watch our screen.
Oyi, men qo'rqib ketyapman.
Bolajonim, sen albatta tuzalib ketasan. Men doim sen bilanman.
Ukollardan qo'rqyapman.
To'xta. Qayerga qochyapsan? To'xta. Og'rimaydi, qo'rqma, qo'rqma.
Saratonni erta aniqlaganimiz yaxshi bo'ldi. Salom bolakay. Sen cho'chima.
Men yashashni xohlayman.
Sen albatta yashaysan. Men senga ishonaman.
Hayot uchun rahmat.
Azizlar, ko'rib turganingizdek, rolik birozgina g'amgin, ammo jamiyatimizdagi bor muammo va bu muammoni hal qilishga bel bog'lagan barcha mutaxassislar bugun mana shu yerda jam bo'lganlar. Anjumandan ko'zlangan asosiy maqsad ham shu: shifokorlarning tajriba almashishi, yangi yondashuv va texnologiyalarni o'rganish, bolalar saratoni tashxisi va davolash usullarini takomillashtirish ishlarini mana shu yerda 2 kun davomida muhokama qilishdan iboratdir. Azizlar, endi esa mamnuniyat bilan bugungi konferensiyani ochib berish uchun so'z O'zbekiston Respublikasi Sog'liqni saqlash vaziri Asilbek Anvarovich Xudoyarovga. Marhamat.
Assalomu alaykum, hurmatli xonimlar va janoblar.
Good day, dear ladies and gentlemen, dear colleagues. I'm very happy to see you all here today. We have gathered with all the specialists of oncologists and oncohematologists, and here today I'm very grateful for meeting today because the conference is very valuable today regarding the oncohematology sphere, related to oncohematology sphere. And our respected, honored president, he initiated this initiatives in order to support oncohematology, and also the First Lady of Uzbekistan, Ms. Iraj, is supporting this initiatives to support oncohematology, and I think this is the first step, and I think this is a very good thing that we can reach a very good result. And if you allow me, due to the fact that we have foreign guests here, I will speak in Russian. Dear colleagues, dear participants of the conference, dear ladies and gentlemen, on behalf of Ministry of Health and on my own behalf, I am congratulating you with the starting of the work of the scientific practical conference regarding the new horizons of the diagnostic of oncological and hematological diseases in children. Today, this is very important, the most important sphere in medicine. We all understand the early diagnostics as well as innovative methods of treatment and complex rehabilitation plays of utmost importance in order to improve the quality of life of our small patients. And this is the minimum program, but we also have the maximum program. Lately, in our country, we are conducting certain works in order to develop the oncohematological aid and service for children. There were certain degree drafts were prepared, and currently our professionals they are preparing the national strategy against the cancer, which is planned for 2030, and recently, very soon, we will provide this draft of this document, big document. By the support of our government, certain solutions are taken in order to improve the pediatric sphere and oncohematology sphere. Every day we are working on this in order to improve, so our population will feel comfortable and they will have certain very good environment. So, based on that, they will have general better services provided by the medical use staff, and certain material technical bases are also updated, and certain innovations are implemented, and palliative care is also developing in order to support oncohematological children. And the main problem is now we need to focus on development of the primary healthcare service, and we need to develop the main algorithms so the early detection of certain diseases should be implemented. We need to start the training. We need to start training our colleagues who are working in the very difficult area. This is the primary healthcare sector, due to the fact that we have issues with the early detection. That's why we still have issues, and that's why we still have high lethality cases. And within this the draft, we also developed the screening programs as well as the monitoring of the patient's condition. In addition to that, we are providing with these patients with the modern medicines, and of course we pay attention to the international collaboration as well as the exchange of knowledge, which will allow us to learn and study. Uzbek people, we are not afraid of competition. We just want to learn from the people who are better in that, in order to learn from them and develop it in our country. And it will be good if we can also attract the foreign expertise to Uzbekistan and also adapt it within the conditions of Uzbekistan. And taking this all into account, I would ask to applaud our guests who, even with their very tight schedule, they could find time in order to participate in this conference. That's why I want everyone to applaud them. Uzbekistan is within the sense of the list of the countries based on the heads of the based on the information provided for us by the head of the WHO on the works conducted in order to fight combat against the cancer. And in this regard, we are providing certain works in order to support the oncological pediatric oncology in our sphere in order to improve the treatment and etc. In addition to that, Uzbekistan is chosen as a country in the global platform in order to provide the access to the medicines to treat the cancer. From 2021, the WHO and Medical Center St. Jude, they created the platform, which is confirmed in order to provide non-stop provisioning of the high class of medications for the children from Uzbekistan, which is based on the international modern standards of providing the treatment. In addition to that, we work with many pharmaceutical companies, not only for the import of these medications. Uzbekistan is considered as an open country, and by the support of the president in Uzbekistan, we created very good investment climate here. That's why many people, they want to work here. And our main dream is to have this oncological medications manufacturing to be localized in Uzbekistan. We want to be the representative country in among Central Asian countries to have high technological manufacturing the capacities being here in our country. There are many pharmaceutical companies, and now we are conducting the negotiations, and we hope that the accessibility of these medicines for our children will be good. But in addition to that, we still require the support and consultations of our foreign friends about which medicine is the best one and in which direction we should have to work in oncohematology sphere. There is a very big competition. Everyone will they will try to sell their own medicine, but we will be working based on the evidence-based medicine in order to have the good results, long-term results. Dear participants of the conference, I hope that today within this work you will discuss all the relevant issues related to the diagnostics and treatment of the oncohematology, and we hope that we will collaborate to improve the scientific base, research base. And I wish you all the best, and I wish you all the new openings within the scientific world in oncohematology, and I hope that the success will always follow you. Thank you so much. Mr. Asadbek Alvanovich, we want to thank you for these wonderful words. And in reality, it is very important to make an early diagnosis in children who with oncohematological diseases. And of course, we need to discuss all these points, and we need to raise the awareness among the population, and that's why we will ask mass media to share and raise the awareness. And dear friends, and now I would like to ask to the floor to the director of the Scientific Research Center of the Pediatric Oncology, Hematology and Immunology, Ms. Pilatova Jamila Shagaratovna.
Good morning, dear friends, dear colleagues, dear friends. I would like to greet you on our scientific and practical conference, New Horizons in the Diagnosis of Oncological and Oncohematological Diseases in Children. And it is International Day with Fighting the Cancer. And these days, February 14 and 15, are very special for all medical community. And it's not just dates in the calendar, it is a reminder about children cancer is not the end. If we have enough knowledge, technologies, support from the government, and before that, if we have the desire in our hearts to save lives. Today, children oncology and oncohematology is really developing in Uzbekistan very fast with the support of the government, with the big attention paid by the President of Republic of Uzbekistan, the Minister of Health, and the support of international organizations and communities and all medical co-workers. Our country's oncology and hematology for children are really going to the new next level, and the government is creating all environment where our specialists can work on the higher level. They can exchange experience with the leading international centers to build capacity and to exchange the best practices. And this is a very important thing, and we are very proud that our government is doing everything it can to save children's life, to strengthen national health. To fight children's cancer, it's not only about medicine, it's a difficult mode for hospital, for medical workers, for the government, and it is a challenge which requires not only giving all efforts, but giving everything we have. Because today in the buildings of hospital, we are fighting for their lives, because we see desperation in the eyes of the parents. We see the pain of children struggling, and we cannot let them down. We cannot stop. We cannot give up. We have to go and move forward. We have to really be more effective in treatment to more survival rate. I would like to share my deep gratitude to our local and foreigner colleagues, scientists and doctors who do not look at themselves, but they really constantly struggling to save lives. Thank you for your professionalism. Thank you for everything you do, and thank you for humanity. Let this conference be one step to the victory over children cancer. Let every report, every discussion will bring new knowledge, new ideas, new opportunities to save these little lives. In the name of the science, in the name of the health, in the name of our future generation. Thank you very much. I would like to share a very small presentation, and it's about what we plan. Today we face the please hold on. Please. Today we face the crucial task of establishing an effective, modern and sustainable system for combating childhood cancer in the Republic of Uzbekistan. Pediatric oncology and hematology are challenges not only for the medical community, but for society as a whole. Each diagnosed case is the fate of a child and their family, which means it is our responsibility. In recent years, our country has been implementing a large-scale healthcare reform aimed at developing specialist oncological and hematological care. This is not just modernization of individual institutions, but a systematic approach that encompasses diagnostics, treatment, medication provision, personal training, and family support. Decisions made at the state level have enabled the formation of national strategy based on advanced international practices. This is especially important because the incidence rate remains high, and timely diagnosis, along with access to modern treatment methods, are key factors for survival. Oncological and hematological diseases in children require a special approach. Unlike in adults, cancer in children most often develops rapidly, and every day of delay reduces the likelihood of successful outcome. Therefore, one of the top priorities is minimizing the time from the first symptoms to the diagnosis and from diagnosis to the start of treatment. The implementation of standardized clinical protocols, the expansion of diagnostic center networks, and the provision of trained specialists steps are needed on the ground to change the current situation. Early diagnosis not only increases the chances of recovery, it determines the child's fate. One of the most significant achievements was the establishment of the Autonomous Center for pediatric oncology, hematology, and immunology, which made it possible to focus resources exclusively on treating children. The separation of pediatric and adult oncology is a fundamentally important step, as oncological and hematological diseases in children have different mechanisms of development, require different treatment protocols, and demand a special approach to rehabilitation. The separation of pediatric oncology into independent field has enabled the implementation of specialized standards tailored specifically to the unique characteristics of a child's body. This is a key to improving the quality of treatment. Recognition from the international medical community is an important indicator. It confirms the correctness of the ongoing reforms. Uzbekistan inclusion in the WHO global initiative is not just a prestigious participation, but an opportunity to integrate into the global system for combating childhood cancer. The partnership grants us access to the best global practices, specialist training programs, modern treatment protocols, and diagnostic methods. The main goal is to reach the level of developed countries where the survival rate of children with oncological and hematological diseases is 80% or higher. According to the set objectives, by 2030, the survival rate of children with oncological and hematological diseases in Uzbekistan should increase from 17% to 60% or higher. They're not just numbers. Behind every percentage point are saved lives. Ensuring access to medication is another critically important issue. Modern anti-cancer drugs are highly effective, but also very expensive, making them inaccessible without government support. The inclusion of our country among the pilot nations of the global platform for access medicines has made it possible to ensure uninterrupted supplies of essential medications to 16 key medical institutions in our country. More than 5,000 children annually are guaranteed to receive the necessary treatment. It is important to understand that medicine is not just a component of therapy, but the foundation of successful treatment. Without high-quality pharmaceutical support, it is impossible to achieve consistently high survival rates. It is necessary to focus on the latest advancements and strategic initiatives that have become a significant milestone in the development of pediatric oncology, hematology, and immunology in the Republic of Uzbekistan. The state recognizes that cancer treatment is not only about medication therapy, but also comprehensive support for patients and their families. That is why a fund has been established as a center to improve the health of children with oncological, hematological, and orphan diseases. The fund operates without the status of legal entity. This allows it to be a flexible tool in addressing pressing issues. The creation of a national registry of donors' bone marrow and stem cells in a historic achievement to our country. Bone marrow transplantation is the only chance for survival. Starting from July 1, 2024, patients aged 18 to 21 can continue receiving treatment in pediatric oncology centers. Adolescent oncology differs from adult oncology, and treatment in specialty pediatric centers significantly increases the effectiveness of therapy. Continuing therapy in familial conditions improves treatment adherence and reduces the risk of relapse. Thus, the state ensures continuity of therapy, which significantly increases the chances of full recovery. The analysis of disease incidence by region shows that the main burden falls on the city of Tashkent and the Tashkent region, where the highest number of oncological and hematological cases have been identified. High rates have also been recorded in the Kashkadarya, Samarkand, and Fergana regions. These data highlight the need to develop specialized centers in the region so that children do not lose precious time waiting for consultations or hospitalization. Human resource policy is one of the key components of the strategy. High-tech equipment and modern medications are important, but without qualified specialists, they will not have the maximum effect. Our country is focusing on training professionals. Doctors undergo international advanced training programs. Incentive mechanisms are being developed to reduce staff turnover. International cooperation is being stringent, allowing for the implementation of advanced treatment methods. Without a strong medical school, it is impossible to achieve systematic improvements in pediatric oncology and hematology. Our goal is to create a system where a child's place of residence doesn't determine their chances of recovery. To improve accessibility and treatment effectiveness, a clear patient routing system is being implemented. This system eliminates delays and ensures that the child is directed straight to the center where they receive the best possible treatment. Thanks to the implemented model, family doctors and outpatient clinics will be able to quickly refer patients to the next level of diagnostics. The Interregional Children's Clinic will provide in-depth examinations. Interregional specialist centers will take the treatment of complex cases. The Central Oncological and Hematological Center in Tashkent will serve as the coordination center for the most complex patients. After the main course of therapy, children will be able to receive rehabilitation and supportive treatment closer to home. This structure will help reduce the time from the initial consultation to the start of treatment, which is a critically important factor for success. Digitalization is the future in medicine. The implementation of electronic medical records, monitoring system, and a unified database allow for real-time tracking of patients' conditions, analysis of treatment effectiveness, and coordination of doctors' work. The digital platform will enable the creation of a unified oncology register, ensuring complete data transparency, the ability to respond quickly in complex clinical cases, and automated control over the availability of medications and medical services. These digital technologies are becoming a tool for improving the efficiency of the entire oncohematology care system for children. The reform of pediatric oncohematology is not just about improving individual processes, but about creating a fundamentally new healthcare system. We cannot afford to stop because every last minute is a missed opportunity to save a child's life. By creating a system in which every child, regardless of diagnosis, gets a chance for the future, we are laying a strong foundation for the nation's health.
Immunologiyasi
In reality, that Scientific Research Center of Pediatric Hematology, Oncology and Immunology, as she mentioned, as the director of Jamila Shagaratun, as she mentioned, there is not only statistical information, of course, behind the statistics lies the big work conducted by two specialists, as well as the task that their group should have to conduct and follow. And that's why we want to thank the director as well as the whole management team of this center for their work. We know that the work of the specialist is very important and unique, and that's why we want to thank deeply from our heart, and we wish you all the best to you. And dear friends, we will continue. It was mentioned that awareness raising is an important factor in working related to the diagnostics of pediatric oncology, and by the help of the specialists, foreign specialists within this sphere, and their consultation and support is very important. That's why I want to pay attention the importance of the guest of our conference today, the director of the Pediatric Center Oncology Hematology from Russian Federation, academician of the Russian Academy of Science, Mr. Rumyantsev Alexander Grigorievich. I would like you to pay attention to the screen. He has his video message reported.
Dear colleagues, today in the International Classification of Diseases, MKB11 includes 4 groups of diseases. These are brain tumors, tumors of the hematopoietic and lymphoid system, malignant neoplasms of organs and tissues, and benign tumors. It should be noted that pediatric oncology is present here at all levels. Moreover, it constitutes the majority of patients with tumors of the hematopoietic and lymphoid tissue. These include leukemias, lymphomas, lymphomatosis, histiocytosis, and other disorders specifically affecting the blood system. 25% are tumors of the central nervous system, and 25% are tumors of various organs and tissues, typically solid tumors that develop from the embryonic tissue remnants in a child. It should be noted that the main principles of organizing medical care in pediatric oncology and oncohematology focus on early detection and diagnosis of oncological diseases, as well as specialized consultations that require diagnostics and treatment planning. This primarily includes a comprehensive examination with mandatory pathomorphological confirmation of the diagnosis. Includes the mandatory development of clinical guidelines, medical economic standards, selection of treatment protocols, and most importantly, the formation of a multidisciplinary team of doctors, which includes oncologists, surgeons, radiologists, and other specialists involved in the patient treatment. The third aspect is a very important and fundamental. This is a drug treatment, combined surgical intervention, radionuclide therapy, combined treatment methods. In other words, this includes empirical and targeted chemotherapy, special conditions for supportive care, immunotherapy, hematopoietic stem cell transplantation, and cell therapy. These are treatment methods that are already in use for children today, but haven't yet been fully developed for adults. When it comes to cancer treatment, it is very important, the first and foremost, to have a well-organized medical facility, which should include an inpatient unit and day hospital, which would allow patients who are staying at home to come in for specific stages for treatment. Additionally, the organization of rehabilitation is essential. This includes the first and second stages, as well as outpatient treatment in clinics and at home. A very important issue is monitoring and follow-up care. A child diagnosed with an oncological or oncogenetic disease is monitored for at least 5 years if there is no recurrence. If recurrence occurs, then each post-recurrence treatment also requires monitoring for 5 years. This means long-term monitoring of patients, during which the family, child, and the patient must be present in the doctor's office to address technical issues. This also includes support for families, as well as education and training for children and parents, which we have implemented not only in Russia but also in Uzbekistan. This involves preschool and school education for children in medical institutions, the establishment of hospital schools, the implementation of the so-called Russian projects, which we are all well aware of in CIS countries. It should be noted that the patient routing rules for those with oncological and medical hematological diseases require a legislative framework. In Russia, this is governed by the law on the protection of citizens' health in the Russian Federation, which outlines state control and mandates the use of clinical guidelines and medical care standards, including the authorization for the use of labeled drugs in children, meaning medications not used according to the official instruction, because clinical trials of oncological drugs in children are not conducted for ethical reasons. This also applies to special legislative frameworks for monitoring and long-term dispensary drug provision. It should be noted that the orders of the Ministry of Health, which establish the procedure for providing medical care and regulate the provision of genetic diagnostics, medications, and technologicals, must be mandatory for children with orphan diseases. Clinical guidelines developed by the professional medical community and approved by the Scientific and Practical Council of the Russian Ministry of Health are available on the ministry's website, as well as on the website of our Society of Pediatric Hematologists and Oncologists. They can be fully utilized, including in Uzbekistan, as they are publicly accessible and available. It should be noted that one of the key steps in the patient routing process for oncological and oncohematological diseases is the initial consultation and diagnosis. This typically involves a pediatrician or a general practitioner whom parents visit at their local clinic. At the first signs of symptoms, the doctor assesses the child's condition and refers them for initial examination. The initial diagnosis must necessarily be conducted at the clinic or a district hospital. This includes methods such as blood tests, biochemical blood analysis, ultrasound examination, and X-ray examination if needed. In cases where abnormalities are found in the blood test or detected by the doctor, if there are abnormalities in organs and systems suggesting a hematological or oncological disease, the pediatrician refers the patient to a pediatric hematologist oncologist who confirms the diagnosis. Then they prepare the necessary documents or a document package for hospitalization. The patient is sent to the nearest regional center for a detailed examination where a final diagnosis is established, including pathological studies. At this stage, a medical board is involved in the treatment program. In software treatment such as council consists of several specialists participating in the treatment. For example, in the case of brain tumor, up to 8 specialists may be involved, including not only oncologists but also neurosurgeon, neurologist, maxillofacial surgeon, rehabilitation specialists, radiologists, and radiation therapists, and others. It should be noted that in the Russia Federation, highly specialized treatment is concentrated in federal centers for pediatric hematology and oncology. There are several such centers. One of them is a central facility, our center, the National Center for Pediatric Hematology and Oncology, widely known as the Dmitry Rogachev Center. The same situation exists in Uzbekistan, where the National Center for Pediatric Hematology, Oncology, and Immunology is also present. This is a central institution that addresses all issues, including surgical interventions and high-tech treatments such as a bone marrow transplantation, nuclear medicine, and more. In other words, this center takes the lead. It oversees all centers located in the federal subjects using various methods, primarily telecommunication connections. For example, the optimal routing and organization of medical care for a child with acute leukemia. Parents notice symptoms such as fatigue, paleness, bruising, and frequent infections, and they turn to a pediatrician. If the pediatrician detects abnormalities during the child's examination, most often in the blood test, and observes abnormal indicators, they refer the child to a hematologist. A consultation with an oncologist and hematologist is conducted using specialized tests. This includes a detailed blood test and a bone marrow function analysis to confirm the diagnosis. And if such a diagnosis is confirmed, the child is referred to an oncologist center where a morphological diagnosis is established and the necessary tests such as CT scans, MRI biopsy, and genetic tests are conducted. Then special treatment begins, including chemotherapy, radiation therapy, and immunotherapy. It is very important that the multi-center team is formed here, which includes oncologists, hematologists, surgeons, radiologists, psychologists, and others. In this situation, courses of chemotherapy and radiotherapy are planned. In our practice, patients with lymphoblastic leukemia receive a unified standardized protocol developed in Russia, which is now also used in Uzbekistan. This is the protocol MB90 2015. It includes a whole range of drugs, a total of 8. And most importantly, the outcome results in approximately 80 to 85% recovery for these patients. Therefore, we carry out all of this in coordinated and systematic manner to ensure that patients receive a unified standardized treatment. This is the Moscow-Berlin protocol, which we implement here. You can see that event-free survival exceeds 80% and overall survival is over 90%. And this issue concerns a vast number of patients who have undergone this therapy. In total, under the latest protocol alone, we have nearly 8,000 patients. Overall, this protocol group has experience with approximately 17,000 patients. In cases where a child in the first year of life has congenital leukemia, one of the protocol variants is used, this called MLL baby, which provides approximately 80% survival for children with congenital leukemia. In cases where there is an opportunity to use chemoimmunotherapy, today's recommendation concerns a new treatment philosophy aimed at eliminating regional glucose in children. This is blinatumomab, which is used in combination with therapy. Our current 3-year observations on the effectiveness of the therapy, chemoimmunotherapy, show that the patient survival with chemoimmunotherapy reaches 95%. Recovery in these patients is, of course, a giant leap in the field of patient treatment. And naturally, the National Medical Center, named after Dmitry Rogachev, widely utilizes transplantation, which should be a mandatory component of a combination therapy. For patients with various types of hematologic diseases, in particular transplantations from haploidentical donors, that is from biological parents, yields better results even compared to unrelated transplants when performed correctly. These technologies have been developed by us and we are ready to share them, including with our colleagues in Uzbekistan. And lastly, over the past 5 years, the Dmitry Rogachev Center has been using gene-targeted therapy, the so-called CAR-T therapy. This is a breakthrough approach in tumor treatment, and it applies to those patients, the 10-15%, who have unsatisfactory treatment outcomes with the chemotherapy. For these patients, CAR-T therapy, gene-targeted therapy, that modifies T-cell receptors to attack tumor cells achieves an average recovery rate of approximately 60% among those who previously had no chance of recovery. It is important to know that CAR-T therapy is not a panacea. It is one of the conditions for treatment. Since it is a combined approach, after the patient undergoes CAR-T therapy, they experience depletion, a reduction in cells in B-cell tumors in the human body. When minimal residual disease (MRD) test is detected through testing, in such cases, a bone marrow transplant must be performed to ensure long-term remission. This is now a mandatory step after conducting the test, cardiotherapy. Using this position as an example, I would like to say that this also applies to other diseases. It is very important that we have developed and we have now proposed documents related to the long-term monitoring of individuals who have undergone oncological diseases. This includes the regularity of medical checkups, monitoring of treatment side effects, endocrinological control, psychological support, social adaptation, education for parents and children, and individualized approach to patient treatment, and such in order for the medical supervision of children who have recovered from cancer. We have now handed it over to our colleagues in Uzbekistan for its adaptation to the conditions of the Uzbek state. Thank you for your attention.
Dear colleagues, of course, you had certain conclusions out of this presentation, and we will continue our presentation, dear guests. And now the floor is given to the General Director of the center, which is named after Dmitry Rogachev. We will give the floor to Mr. Grachev. Nikolai Sergeyevich. Good day. If you allow me, I will congratulate you with the holiday, I'm congratulating you with the meeting and conducting this conference. It's not that easy to give a speech here, but it's an honor for me to be here at the plenary session. And first of all, I want to thank Ms. Jamila Shagaratovna for conducting this event, for inviting the Russian delegation, and we are very happy for that, and that's why we want to say thank you so much. We are honored to be here. And of course, I want to thank all the hematologists, oncologists, and all the classical specialists here from this country. We have here Mirza Yarovich. He is the founder of the oncologists the school here, as well as the hematologists, the therapists, as well as oncologists. Thank you for the work you do. Within the framework of this meeting, I would like to say certain organizational points regarding the work of the Oncohematological Service of the Russian Federation. Based on the publication, we cannot be, of course, be separated from the international society and the pediatric oncology. This is the burden which lying on every human being, and every day that we are fighting, combating against the cancer, we should be very. We have all the cards of this we fight, and this is the publication of the Lancet Oncological division of this Lancet journal, and we understand that the amount of that children from 0 to 14-year-old will reach up to 11 million children based on the data 2020-2050, and half of it will be only diagnosed, and we understand that 6.1 million of these children will be not diagnosed during their life. And here I saw the slides which were before, and I changed the plan of my presentation. What is the reveal rate of the? It doesn't mean that the amount of children with oncological disease has changed, and which is the early detection is earlier, is conducted better now in this country. Unfortunately, certain diagnosis is not made on time. We need to understand that objectively all the investment as well as the social economic investments, they are absolutely needed, especially economically. We understand that it's relevant. We understand that every dollar that we spend for the pediatric oncology, we receive $3 of benefit when our patient is healthy again and comes back to the social life. And that's why we are providing the new life for the child, which will be socially adapted. And certain publications are talking about that. And we talk about the usage of the radiotherapy as well as the other one, surgery. It's based on, again, on the economical development of the country. We can see that the developing countries with the which has low income, lower middle income, upper middle income, and high income, they have different data about the chemotherapy, but radiotherapy is also depends on the resources of the country which is existing within certain country in order to fight against that disease. And in addition to that, we need to understand the development of the systemic personified target therapy by the prognosis will not only decrease but also improve the quality of life, and decrease the lethality, improve the quality of life. And when we talk about the epidemiology of the disease, there are different causes, neuroblastomas and etc. Here, currently in Russian Federation, within the fight with pediatric cancer, we talk about that the beds, they are located in 10 federal centers, and out of 110 clinical objects of facilities of the Russian Federation. Here we can see that more than 3,500 oncological hematological beds are existing for children, and 450 doctors, pediatric oncologists, as well as oncohematologists, they are existing. You know that we have certain restructurization, and we are changing the specialization of the oncologists, the pediatric oncologists, as well as pediatric oncosurgeons. And now we can see the amount of the surgically treated patients, and also the children under the observation. There are more than 30,000 children who are under the observation. In order to control, we are conducting the registry of every region of our country. This is a very complex like a survey, and it should be actualized every year and updated, and within the center they are updating this information, and they need to have, it needs to be integrated with all the database. Based on this registry, we can control somehow the processes and the revealing detection of the cancer. In 2025, we want to improve the version of this survey, and in addition to that, we conduct the benchmark, and this is the electronic system which might be curated in online format, so we can receive information about the pharmaceutical provisioning and etc. So this is what is developing in the structure within the healthcare ministry of our country, and our minister, he is supporting this initiative and this work. We are conducting this work under his leadership on the creation of the electronic systems as well as the passports of the service of pediatric hematology and oncology. In 2025, we are ready to launch the third version of it, which will allow us to control the diseases, the diagnostics, the treatment volume, and it will affect strictly the result. That means the survival rate. That's why we have the perspectives in this. And the accumulated results by this center is considered to be the National Pediatric Center of Pediatric Oncology, Hematology, Immunology under the name of Dergachev. And this is the short background. Maybe you know about this information. We have different epochs, and next year we will celebrate 35 year in just 91st, the first decree was signed on creation of the center. That's why we will celebrate 35 year, and we will call you to join us to celebrate. And currently, we have 5 Institute of Immunology, Institute of Pediatric Surgery, Molecular Experimental Treatment, as well as the other center is also considered to be the part of our complex, because we need to conduct the complex approach to treat those cancers in children, and it will include the rehabilitation as well as the early detection and etc. Of course, we mentioned the important aspect. This is the transplantation of the bone marrow. Yesterday, we were happy to be a visitor within the Pediatric Center of Pediatric Oncology and Hematology, and we saw how these procedures are conducted here. And Mr. Academician, he mentioned, our colleague mentioned that without transplantation of bone marrow transplantation, we cannot go through the stage to provide a combined treatment for the certain diseases, oncological disease. And see here, this is the information about the autologous as well as oncogenic growth of the diseases. And here, we can see the cell therapy methods also included, and I will talk about it separately. I should have to say that transplantation of the identical donors, when they are they can be conducted based on the improvement methods to clean the transplant, is considered to be a very economically feasible as well as a good model in order to conduct this bone marrow transplantation, and it has a very low risk of complications, like less than 5%. It is conducted widely. Conducting the mapping cell therapy starting from 2018. This is a wonderful alternative. This is the new vector of development. This is the new and you know that this is a this is the new therapy method, and we conducted this therapy for more than 200 patients for the last few years, and more than 60% of them, they have long-term survival rate. And that's why when we talk about the treatment approach, bone marrow transplantation is important, and our center is conducting that. And currently, the Russian Federation is conducting the bone marrow transplantation in many centers, such as Gorbachev and other centers as well, and as well as within the facilities of the Russian Federation. And this kind of centers are opened in Ufa, Kazan, Rostov, and etc. And we are trying to solve this issue within the mass scale of the country to cover the whole country. This is the MAP cell procedures starting from 2018 within the center of Rogachev. Radiation therapy is conducted within our center. In 2024, 382 children conducted went through the radiotherapy due to the fact that radiotherapy is conducted in many courses, and that's why we need to understand that combined therapy is very important. And that's why it should be under the curation and supervision of the pediatrician oncologists, and it should be reported. Surgical treatment types. This is a very good developing direction, and we also understand that pediatric surgery, oncosurgery is developing based on the adult one, and we conducted close to 3,000 surgeries per year, most of them based on the high technology directions, but it's in our center, but not every region can conduct this kind of high-tech surgeries. We understand that they can do the biopsy and etc., biopsy taken and etc., but operation surgeries different pancreas as well as the other systems. It should be concentrated within the national federal centers. And also we have the same system in our country. We have two beautiful departments of oncosurgery, and they will conduct the accumulation of the whole work. Here is the example of our achievement within the face resectional surgeries and the plant surgeries as well, and we are currently developing the individual growing prosthesis, and we patented two new findings, and within the Russian Federation it is related not only to the face sphere but also the movement apparatus, as well as all this precision medicine is conducted systematically in our country. We are conducting the organ saving surgery, so whenever we are talking about removal of the different malignancy within the jaw, we try to save this jaw part as well as the aesthetic view. We want to keep the aesthetic view in jaw sarcoma, and it's very important within the pubertal period. And we have more than close to 100 patients like that who are undergoing this kind of surgeries. And this is not only achievement. I'm showing the work of the growing prosthesis which were developed by us, and the surgery of the skull base, and we are working on this, and currently we can do many surgeries based on the skull base, endoscopically without a big resections made, and we have more than 50 cases per year. We need to concentrate the big capacity of the country. I think you can do it same within your center because you have the pediatric population where you can develop certain methodology and use it. And before we use transfacial different resections, but now it's different. There are different videos provided for that in order to close the defects of the skull base by different tissues. This is how it is done nowadays by the scheme provided within this video. 3D reconstruction of the liver malignancies is quite common, and many surgeries are conducted laparoscopically, and we are actively including within the international program with our international colleagues, and it will minimize the blood loss within the surgery, and it is a very good surgery. In addition to that, we conduct a combined surgery with cardiosurgeons when the malignancy enters the heart, and we are conducting at the same time simultaneous plastic surgery with removal of this malignancy and restarting the heart work again, function again. And we are also trying to save the vessels as well, and we are conducting it in our center. This is our achievement of our center, and we have close to 5 surgeries like this per year. And the prosthesis. Currently, we understand this is one of the main methods to treat the malignancies of the articular apparatus, and this is the. Currently, in December, we made the growing in the prosthesis, and now we developed the system of adding this in the prosthesis through the funding provided, which is called the fund of Fond Dabra, and those kind of surgeries are conducted by 2 centers named under Brogachev and Blokhin, which is allowing us to conduct many cases. And last year we conducted 93 of them, and I think this amount of surgeries are conducted in OncoCentral, other one, and it will improve the quality of treatment and the low complications of the surgery, because our brigade, our team, has a very good specialty in that. In addition to that, we are conducting the individual 3D PK. This is new direction for us, and we are actively using it now. Same like stereotactic surgery. This is also implementation of the last years, and we start to use the stereotactic frames, and we could find the very difficult localized tumors. I will not stop on the different aspects aspects. There are very interesting methods which are locally implemented now, but I will not stop on this whole point. But by summarizing my presentation, I should have to say that a new method should be used in every region, and in the new stages should be conducted, of course, in every region. But the high-tech surgery should be in the cell product should be used in the big centers, like in the Republic of Uzbekistan, in Russian Federation, because we all go together, because the trends is towards the safety of the patient as well as the fast recovery and using the old induced methods of therapy. And we understand that in pediatric oncohematology should be like that, and I was trying to explain it in a easy scheme. And as academicians said, this is a protocol. We need to follow protocol, and that's why we need to observe these patients. We need to provide rehabilitation program for them, and in addition to that, we need to rehabilitate them socially, physiologically, and physically. And this all information is conducted, presented, and this all is done in order to help survival rate of the patients, but for the best of the patient. Thank you so much for your attention. Thank you so much, Mr. Nikolai Sergeyevich, for the wonderful presentation, dear guests. Now we give the next topic is here, the relevant problems and issues, and the floor is given to the head of the department from the medical center named after Pirogov, Polivichenko Elena Vladimirovna. The floor is yours.
Dear colleagues, let me start with the words of gratitude to the organizers of this conference for opportunity to share of our experience of our country and colleagues the development of palliative help. Jamila Garatana, thank you very much. It's not our first touch to this topic. After these great successes in comprehensive technologies of children oncology and hematology, I will tell about children who cannot be cured, cannot be treated. And I think it is one of the psychotraumatic specialist situation when you have untreatable patient. And I would like to start with this map. Because International Atlas of Palliative Care 2020, it is the World Atlas. We are called, so we can understand it's not equal development, and it's not also equal with the children oncology. If you have dark colors, it is a higher development, and I am happy to say that Russia Federation, according to this atlas to the world, it is level 4A. The highest is level 4B. It's countries where hospice and palliative care are at the preliminary stage of integration into the health system. According to this atlas, out of 198 countries, we have 21 countries, and Russia Federation is one of the 21 countries. So here I would like to show what we already have in Russia, that the first palliative help is going to the legislative base of Russia Federation. It's only in 2011, and it is diversity of the types of services, variety of suppliers. It's awareness of it's awareness about palliative technologies among health workers in society. Also, the current strategy with its regular assessment, availability of morphine and some other painkillers, and it's a very actually serious barrier for a lot of societies. And the last but not least, educational programs and the National Association of PP, and we have actually two associations, and I am representing one of it. I also would like to show you a very famous slide. It's slide from 2007, and it's actually sharing what makes palliative care sustainable. Of course, it's state support, and we have it in Russia. We have federal governance. We have state program of health development, state support programs, and relevant legislative norms, even free programs. We also have roadmap, and we have subsidies, and we have up to 3 billion rubles to the development of palliative health. We also have here the umbrella image, and it is like reflecting that the government is giving this support. And we also, of course, have this availability of drugs and medicine, and of course it is education in the field of palliative care, and of course it's to develop regions. If you look at this picture, what is understandable under palliative, like it's like a code. We would like to close something, and it's like it's a psychological challenge not only for the family but also for the professionals. And palliative care today is like a triad. It's like a medicine itself, and it's also quality treatment, and it's not only like functions of nurse but also a function of people who are taking care for patients, because all of this implemented with the aim of improving the quality of life of terminally ill people. And in the whole world, the palliative care patients, children are united in very different kind of diseases, and a lot of diseases are neurological character. And if we look at this as a triad, we can see that it's like medical interventions, it's events of psychological nature, and care. And all of this is for improvement quality of life of incurable patients. Also, I would like to show you a slide with integration of palliative care with other types of medical care for children with cancer, and it is connecting with primary health care for children, and of course with specialized use types of medical care for children, including children oncology and oncohematology. And it's also important for me to show you the this type, and it is called the bow tie model of the 21st century palliative care. You can see the reduction of this triangle if it's uncurable, but we can see the pink triangle is going to increase, and it's like the role of palliative care to incurable patient is becoming dominant. So it is unifying the treatment of it's like a modern approach to give this and that services. So the palliative care, it's not only at the end of the life. It's very important when we talk about integration, and I started with the World Atlas to show that the palliative care, it's not only a task for some special people in some special places for special patients, but it is the task of the health care system overall. And in our country we have the levels. It's the primary pre-hospital care, and the primary medical, and the specialized. And the red triangle, this is hospices, it's ambulatory, and it's also colleagues, and it's like one-day hospital. If you look to the professional standard, we have this document which are confirmed by the Ministry of Labor. It's like professional standards, like what district pediatrician should do. So he should assess the clinical picture of diseases and conditions requiring first aid for children, provide primary health care to children in accordance with current clinical guidelines, and taking into standards of medical care and refer children with disabilities leading to disruption of their vital function and medical organization providing primary medical care to children. And we have a lot of courses on qualification for this polyclinical circle. And I would recommend to whom who are interested in development palliative care as much as possible to go with this information to the first circle. So you can also see how our services are organized. All of them are multidisciplinary. Like it's always about multidisciplinary. I don't comment on everything which you can read in the slide, but pediatrician should be like it's on a 0.25 rate, but he is in this palliative care services. This is also, you can see the multi-professionalism in the work of mobile like team providing priority care for children and work. It's 17 countries of Europe. So with the highest level of palliative care, in every team they have doctors, nurses, rarely psychology, rarely core social workers, rarely volunteers, sometimes like volunteer organizations, but it's always about multidisciplinary. It's not only about medicine and medical health. Some statistics, some data. So we finished statistics of 2024. I am the leading specialist in the Ministry of Health in Russia, so I can give these numbers. Almost 30,000 children receive palliative care in the Russian Federation. Out of these 30,000, only 1,039 children, they are oncologists, like the number of children with cancer. So it's a lot of there are different kind of patients with palliative care, orphan genetic diseases and other. And what I want to say that we have a lot of successful therapies and other like things we already heard and we will hear. So we don't have a lot of children with cancer who receive palliative care. It's only 4%. You can see it from the statistics. If we calculate this number who get children who received opioid analgesics like strong opioids and weak opioids, we can see that half of the patients, cancer patients, they receive these painkillers. In 2011, for the first time, we had an article of this palliative care in Russia, and we can see how many things were done during 13 years. In Russia, we have 12 hospices, and there are in almost every region. And also, I should show how what can be done in 11 years. We have outreach primary care departments for children, and we have mobile teams of primary care for children. It's 347 teams, so and it's less than 300 of them. Like almost all of them, they were covered by our professional attention, like, and we help them to plan and develop their work. We also have inpatient departments of primary medical care for children, 92, and also palliative care beds for children, 1,487, and usually it's not oncological patients among children. Also, very important thing I would like to note, it's about regime of ventilation of and usually children, they do not use this, but with some brain tumors it is usable when a person when a child cannot use his lungs. So it's I also should illustrate that the development of palliative care in a lot of countries of the world, it is including technologies of respiratory support at home. Also, very important, we have the decree from the Ministry of Health. It's about approval of the list of medical products intended to support organs and systems of the human body provided for home use. And there are about 300 medical elements, and it's very highly appreciated by the government and families. And according to this decree, it's thousands and thousands families. By concluding, I would like to say that the big fragment which is requiring addressing in the society is psychosocial aspects of palliative care for children. Last year, we had GHOST, and it's a system of management, it's human centricity, and this is a new thing. This term means that at the center of process of organization is a person with his or her own values, needs, priorities, and motivation. So it's person-centered care. So it's not about addressing the tumor, sarcoma or something, but to focus on the person as an individual. And the person is more than a patient. He or she is not a simple collection of body parts and medical conditions, and not about just things. I also would like to announce about this international standards of palliative care for children. The publication is available on the fund's website, Children's Palliative. We also have the book. You can download this book. You can just have a look to this like needs of the kids, and every girl and every boy he can have this need, and you can go home now. And for me it's very important when we just understanding how to work with incurable patients. And every doctors can really see these needs as a serious, like take it serious, because we should be very serious to symptoms, diagnosis, provision by medical. But if we can see the real needs, can we see the reality, like of seriousness, that the child, he need a sense of identity and belonging, independence and autonomy. Like, is it really like something important for us? Can we really cover these needs? And there are also some needs among parents, because it's not only about children, but it's also about parents, common needs of parents. And if parents say we would like to we stay together as a family, can we see it as a real need, or we can see it as something not necessary? And this is a challenge, and what we have while we develop this kind of help. I also invite you to use our open resources. We have a lot of resources. It's like a website of the Federal Center for Palliative Care. It's also 2 big internet portals on palliative care. It's about hospice and palliative. And from the Association of Hospice Health, we also have 7 or 8 big conferences every year. I also promise to invite you to our upcoming conferences. It's a big meeting of specialists of our professional lives, and you will see that it is very interesting people, because if you're burnout, you cannot be successful in palliative work. So, by concluding, the components of success, I would say, it's interdisciplinarity or multidisciplinarity. As I said, it's personal, it's people-oriented or person-oriented, it's communication, evidence-based medicine, clinical guidelines. I think a lot of this was already mentioned, and changes in the regulatory framework, legal initiative. Thank you very much for your attention. Thank you very much for your for your speech. Thank you very much for everything you do in this field. We have the next topic: the role of SIOOP Asia in the development of pediatric oncology and hematology services. We will see online presentation, and Doctor and Director of SIOP Asia, Gevorg Tamamian from Armenia. Please.
Good day, dear colleagues. Thank you so much for allowing me to participate in the Pediatric Oncology Hematology Congress here in Uzbekistan. I'm really sorry not to be here myself. That's why I'm in an online format. I hope next time I will join you on site. My name is Georg Tamamian, and I'm the president of the Asian Continental Bureau of the International Society of Pediatric Oncology, as well as the Pediatric Oncologist Mediterranean Group, which includes 2080 members, as well as 110 centers of the cancer centers. And in addition to that, I'm the professor and head of the Department of Pediatric Oncology and Oncohematology in the State University, and I'm leading the Institute of Oncohematology. In addition to that, I'm the main editor of the Onco training. I made my slides in Russian language, but due to the fact that our friends from different other countries here on this Congress, the presentation is prepared I will speak in English, but slides will be in Russian.
We are going to continue our short presentation about the role of SIOP Asia and what we are doing over there. Here on the screen, you see the numbers 6 and 158. What it means. So 6, it's the number of members from Uzbekistan in SIOP, International Society of Pediatric Oncology, and 158, it's the membership from Armenia. I mean, both our countries are quite small, population-wise as well, but I think we have to do some things to change these numbers, and this is our own society. I mean, this is our main society of pediatric oncology globally, and I think first of all, it's our kind of duty to be part of this, what's going on around us, and to be part of the society. About the history of SIO. International Society of Pediatric Oncology was established in 1969, and it's the only global multidisciplinary society which is dedicated solely to pediatric and adolescent and young adult oncology. The members of SIOP are from all disciplines in the pediatric oncology field. So those are pediatric hematologists, oncologists, of course. Those are our nurses, without whom certainly pediatric oncology would not work. Psychologists, nutritionists, epidemiologists, pathologists, rehabilitologists, and many more professions. Of course, I mean, here we should remember also all the other medical professionals, doctors, for example, pediatric surgeons, pediatric radiation oncologists, and all those people who are taking care of kids with cancer. Asia is the largest continent, not only globally, but also within SIOP. And here you see the distribution of the countries member-wise. The first one is the United States with 655 members. Then the second one is India, 162. Third one is Canada, 160. And the fourth one is Armenia, which I mentioned just before, 158. And I think this is the data from 2024, from the last year. I hope this year it's changed more positively. So I think, we have even more members from Armenia. And going forward, the structure of SIOP Asia, we have executive board at the SIOP Asia, which we're trying kind of bring more activities through the executive board to the SIOP Asia activities. And the role of SIOP Asia Executive Board is to support the President in the development and implementation of strategy on how to involve more members from Asia within the whole activities of SIOP. So uh, besides the President, we also have the President-elect, which right now we don't have. We are going to have an election for the president-elect, and the member of the SIOP Asia board also is the past president, in this case, Professor Hori from Japan, and we have 4 sub-regional leaders, and which were elected recently. So for the Euro region, where Uzbekistan is also part of, is Dr. Kirill Kirgizov from Russia, and we have other regions, EMRO, led by Rawat Rihani from Jordan, and YPRO is represented by our colleague Professor Huan Min Wan from China. The CRO region is represented by Dr. Nita Radhakrishnan from India. And just recently, we had also elections for the other um, 4 members, namely representing the nursing part. This is represented by Yan Yin from Singapore. She's very active and actively involved in different activities. And the young professionals are represented by Dr. Hiba Altara from Kingdom of Saudi Arabia, and Dr. Nisrin Amairi from Jordan is representing uh, women in oncology, and the LMIC group is represented by Dr. Shruti Kakar from India. So this is the current executive board of SIOP Asia. And all the time, I mean, the role of the executive board also, as I mentioned, to involve more members within the activities. But all the time we are having many announcements for different committees within the whole SIOP. And I mean, it's very important to have our members from Asian continent to nominate themselves, to move them forward, and to contribute for our society, because we are fighting for the same goal. We are fighting for the kids with cancer. As it is our motto, no child should die of cancer. Cure for more, care for all. These are here you see the functions of this IOP Asia Executive Board. I mean, somehow I summarize some of them, but like if I go through the points, of course, to consult the SIOP Asia president, and then to discuss and establish working groups, to support different initiatives and activities in supporting GICC in Asia, Global Initiative for Childhood Cancer. Then evaluate and come up with the ideas on how to involve different members of SIOP Asia within the activities of the global SIOP. And so on. I mean, I'm not going to read all the points, but you have on your screen. Soon we will have also a new initiative, and it's going to be announced soon, very soon. We are going to have ambassadors of SIOP Asia. So from every country, well, we are going to elect ambassador who is going to represent that country. From the big countries, from the large countries, we might have several members, because our aim is to maximal inclusiveness, so maximally trying to involve all the members. Coming to the our annual meeting, you know, we have our annual meeting, both SIOP and the Asian continent, and this year the SIOP Asia 2025 is going to be in Riyadh, which is hosted by Dr. Hiba Altara in April from 12 to 15. We are going to have a very nice program, so I encourage you to participate in our main annual meeting of the SIOP Asia. And like it is mentioned on the poster, I would just echo, yes, we're stronger together. That's why we really need your involvement and we really need your participation. In 2026, there is a misspelling here. In 2026, the SIOP Asia is going to go to Ulaanbaatar, to Mongolia. Dr. Tsetsek Saikan Batmung is going to be the chair of the local organizing committee. So we are going to have a very nice program there as well, I'm sure. And we would, I would encourage you to if you have any ideas or you want more participation, please just reach out to us and we'll be happy for more involvement from Uzbekistan as well and from the whole region, of course. Tomorrow, on February 15, early in the morning, we are starting also the second global oncothon. This year is organized with the SIOP, International Society of Pediatric Oncology. This is the second time we're organizing it. This is the initiative of OncoDaily, and we're raising awareness and funds for the pediatric oncology. And this year, the funds are going to go to the SIOP to support research activities. Last year, we came together, and as a result of the first global oncothon, we were able to raise around $1.3 million, and which went to a biotech established by two parents to start their clinical trial in pediatric oncology field. So this year, the funding is going to go to the SIOP and to support Young Investigator Awards, to support Career Development Awards, Park Grants, and we would love to have you to participate more actively there. You will have, you will see a lot of surprises. We have confirmations from the almost like all these big, large international societies presidents, and we have this year, like participation also from the celebrities. On I'm sure on social media you already have seen the announcement that world-known celebrities like Richard Gere and his wife Alejandra are going to participate in the oncothon. We will have some more surprises on the 15th. I'm not going to open it up now so that you can stay tuned and follow what we are doing there. The opening will be done by Her Royal Highness Princess Dina, our patron of SIOP and the president of SIOP, Professor Guillermo Chantada. Again, we will start early in the morning, and early in the morning, I think in Japan, Australia, that time zone, and we'll end up in San Francisco when the day ends. And moving forward, this is the photo of the building I visited. I was fortunate and honored to visit in August. Professor Jamila Palatova and her team invited me and our group to visit the beautiful center you have and the nice group you have. And we're impressed by the dedication and the willingness to change the things. Many of the doctors also I know from the past, and I'm sure, with this attitude, with the willingness, with the involvement of all the stakeholders, as well as support from the government, and I know there is a support from the government there, as well as the international community. You will be able to achieve more and have higher results. So I congratulate you again with this initiative on organizing this Congress today, and I wish you all the best. And we are always happy to help. We are here for you, and just reach us out. These are my emails, and I'm always available if there is anything. Thank you very much. Thank you very much, Professor Palatova and the whole team behind for having me today. And I wish you good luck. Thanks a lot.
Спасибо еще раз.
We want to thank our specials from Armenia, but now we will have a short break. But I would like you to pay attention to that the next block will be presented by our specialists from the foreign countries, and it will be presented in English language, and you have the possibility to receive the special equipment, to receive the interpretation. We have here simultaneous interpretation channel available, and you will have interpretation. Dear friends, it's a 20-minute break right now. If it's 11:17 right now, then we will meet with you at 11:34. Thank you.
Shu yerda zalda kutib qolamiz.
Let us continue our conference. And we have a lot of different topics, a lot of different speakers, and all of them are specialists. And if you have any questions, then please note them, and then we can give replies in written form. So please, if you have any questions, keep them noted. We will have special time for giving space for it, and also you will have opportunity to respond. And let us continue our plenary session. As you notice, we have Yelena Vladimirovna here, and she is a moderator. And of course, Mamedova Guzal Bakivna, the deputy director of the Center of Hematology, Oncology and Immunology of Republic of Uzbekistan. Thank you very much. And of course, we will continue. We will have the next speaker from Cleveland University, and the topic, the role of international clinical in Uzbekistan. Mr. Ilya Bukhtiarov, USA. Good afternoon, good morning, everyone. And I have around 2 a.m. night time, but I am full of energy to share information with you. And we, with Dr. Polatov, we see opportunity and the future of oncological services in Uzbekistan. I will briefly talk who I am, and my name is Ilya. I am the graduate of Medical Academy from Kyrgyzstan, Bishkek. And lately, like for 20 years, I have been living and working in US. And since 2015, I am the director of Clinic on Leukemia and Lymphoma and Histiocytosis in Cleveland Clinic, and it is one of the largest system of healthcare system in US. So, by fortune accident, I met Dr. Palatova in October last year, and we just touched some topics which are very interesting to both of us, and we came up with the idea to develop a partnership with the goal of improving indicators of oncological services in Uzbekistan. In my presentation at the beginning, I will just share some parameters, global indicators in pediatric oncology and hematology. Then very briefly, I will share about the main indicators in pediatric oncology in the Republic of Uzbekistan. Dr. Palatova generously share with me. Also briefly talk about leading causes of deaths in pediatric oncology, and the main part will be regarding working together, how we can work together, how we can improve the indicators we already have today, and we will discuss it for sure. So, as it was already noted, and one of the speakers already noted, the children cancer, childhood cancer is rare. And according to this slide, you will see epidemiological different kind of diseases for adult and for child. So the ratio, it was around 50-1 from adult cancer and child cancer. And the main oncological cancer among children, and specifically in infants, it's leukemia, CNS, lymphoma, other anocytes, at the same time with adult and adult cancer, there are very variety and from depending on age, depending on some environmental indicators, maybe lifestyle, and this statistics it shows a lot of cases and approaches for treatment of cancer. So in this slide, I would like to show that in the relevance of problem, how it looks and how it's standardized by age, and if it's like more deep blue. Then it is more oncological diseases in the country, and if you see this is deep blue, it is mostly in the countries of North America, Europe, Australia, New Zealand. So it's like high technological countries with developed infrastructure and also other indicators which are unfortunately they impact the frequency of these diseases. If you look at Uzbekistan, we have Uzbekistan, Turkmenistan, Iran, Tajikistan, Hindi, and if you can see, they are not so many oncological diseases of like in children. It's like if we can just compare the numbers which we have in countries or with developed economy. Oncological diseases, they are the second most common cause of deaths in childhood. From the left graphic, you can see it's American data from 5 to 14 years old, and if you see the main cause is accidents, and the very high rate of accidents which leading child mortality, and also like historically it was very high, now it's decreasing, and also if we see the the rate of mortality from oncological diseases, it's like almost on the same level. And also there are some other factors like congenital anomalies, heart diseases, and also like suicide. There are other factors, but the frequency, they are very, very low with the comparing of oncological diseases. It is worth saying that the frequency of cancer, it is slowly increasing, and it is connected to some factors. We can also discuss it in a different conversation, but it is worth noting that the mortality from oncological diseases, it is decreasing. So the frequency, the numbers of cancer diseases is increasing, though the mortality is decreasing. So if we look at this slide and we look at the mortality level, oncological diseases, as we said, are the second most cause of mortality childhood. The global mortality from childhood onset cancers that we can see. So this is a picture that this is a region, and like we are interested in this region, Uzbekistan, Turkmenistan, Iran, comparing with other countries in the region like the Russian Federation, the Kazakhstan, India, Pakistan. Like due to different diseases, the mortality level from oncological diseases are higher, and it is one of the factors which like push us to find new ways of solving this problem. And as you know, different oncological diseases, new cases in children, it is depending on age of children. Like it's birth state, is which is neuroblastoma, it's Wilms tumor, retinoblastoma, which are occurring during pregnancy stage. So it's later it can be a different kind of lymphoid leukemia, etc. And later on in the late childhood and also teenagers, it's usually it's sarcomas, Hodgkin diseases, different kind of soft tissue sarcoma, and other types of, let's say, adult cancer. And the data which Dr. Palatova shared, they are reflected on this screen. During last few years, recent few years, we took a period from 2022 to 2024. Annual growth noted oncological diseases in children in the Republic of Uzbekistan around 2.5% per year. Overall survival, the numbers are shocking. From leukemia and lymphomas, it's around 42%, and from other oncological diseases, around 42%. So this slide also shows the number of children with new diagnosis. It's like 2022, 2023, and 2024. And as you can see, in 2024, again, we see growth of new diagnoses, new cases of oncological diseases. With the same time, as a minimum, look, as 10% of children, unfortunately, they passed away during 1 year from the, and this data obviously requires serious analysis, and it prompts us to find new ways how we can learn to really be better with treatment of oncological diseases. The reasons of mortality, causes of death during the first year, the main cause is infection, maybe difficulties which we face during the treatment, like treatment-related mortality. And also the first factor is age. Before 1 year, they are more vulnerable group. Then it's also children are and also leukemia and lymphoma, usually it's a high risk group. And the least vulnerable is children from 1 to 12 years. And of course, the type of cancer. The patients with leukemia, they are, it's a lot of difficulties related, and more of it's more difficult to cure than solid tumors or CNS tumors. And of course, the patients who are who needs transplantation of stem cell, they are unique group, and they are, of course, high risk group. And unfortunately, it leads to the early mortality during first year of treatment. And of course, there is a cause of death within 5 years of diagnosis. It can be tumor progression, relapse. And you can see also these two graphics on the slide, like trends, which I already spoke of. And the difference that you should pay attention to the scale. And as you can see, the mortality, and this data, they from publication of European Journal, the mortality during first 3 years of diagnosis, so it's around 10%. And with the hematology, solid and brain tumors. And if we go back, what we already mentioned before, the mortality rate in Republic of Uzbekistan during the first year, it's almost 40%. So by other words, there is something which exists, and if we can change this something, we can be more successful with results of treatment. Going back to the cause of death within 5 years of diagnosis, so few first years, I would just want to share the results of acute leukemia treatment outcomes, how results look like according to the three main problems: standard risk of leukemia, high risk leukemia, and aggressive lymphomas. So, on this slide, you can see the results of protocol, which is already standard treatment, which is being used for the patients who are not on the clinical tests. So as you can see, the mortality rate, the overall mortality rate, and the before first recidiv, it's still around 95%. And in Cleveland Clinic, during last 10 years, we didn't lose not a one child. All of them are alive. They go to remission process and they continue to be in that condition. Very similar picture with the patients with high risk, and of course they requires more intensive care, and historically this treatment is taking more time than usual. But as you can see, the statistics, the trends, they are usually the same. Like it's almost we don't see children whom we lost during the treatment. And according to observations during the treatment, it was up to 6 years. So if you ask on what stage we can say that child was cured from leukemia, then according to the medical canons or laws, in any medical notes, of course, it will sound like leukemia in remission. 3 years, 4 years, 5 years, it's still leukemia in remission. So according to the medical data which were published in St. Jude, and I know that in the conference you will have speakers from St. Jude Medical Center, which is in it was statement that if a child is in remission during 4 years after the treatment, the risk of relapse or less than 1%, then you can say to the parents, we think that your child is healthy. Of course, it will not be like 100% guarantee, but the risk of relapse is less than 1%. So the statistics we have today. And also, I want to show you the results of Burkitt's lymphoma treatment results. It is one of the aggressive type of lymphoma, and the children oncologists, they face it. And as you can see, if patient can be cured according to the standard protocols, standard of care, with the usage of chemotherapy, the survival rate is 80%. But if we can use a combination of chemotherapy and immunotherapy with the rituximab, the mortality, the survival rate reaches more than 90%. After Dr. Palatova and me and the other team members, they touch these aspects, we saw some big approaches or ways how we can improve the dynamics and overall and indicators and overall with treating cancer in children. Of course, it's financing. Of course, it's about personnel, medical personnel, it's infrastructure, and it's and I'm sure it is being done already in a very high level. The patient support, and we already touched this issue. It's very important. And the thing we would like to work together is international cooperation to adapt best international practices, like in the protocols and forecasts. And Dr. Palatova already shared it can help us to implement recommendations will increase survival by 15% by 2030. Happen it or not, we will see it within the time. And our endless conversations with 9 hours time difference, it came up to this project. And of course, it is only in the future to be implemented. It's not even in the paper, but we are moving towards it. And it's about long-term clinical and academic cooperation between the Center of Pediatric Oncology, Hematology, and Clinical Immunology Tashkent, in the representative of Dr. Palatova, and Center for Pediatric Oncology, Hematology, and Bone Marrow Transplantation, Cleveland Clinic, USA, and also I am part of this clinic, and of course, we still have a lot of issues and cases which we. So, what Cleveland Clinic is, very brief. It's one of the biggest systems of healthcare in U.S. And there are. There are four on the territory of North America. It's one in the Canada, in Toronto, Ohio. It's a main campus, and we also have two big centers in Nevada and Florida. And also there are international representative offices in Abu Dhabi and London. And Cleveland Clinic is going to be expanded and to giving access to expert opinions, and we have multiple representative offices in Latin America and Caribbean islands, and the Persian Gulf, and China, India, and who knows, maybe it will be also rep in Central Asia, maybe even in Tashkent. So as I already mentioned, the main campus or HQ is in Cleveland, Ohio State, and that's how it looks like. It's our HQ hospital. Of course, it's a big system, and you can see it's all of this is hospital corpuses, and there's our children hospital, and it has access to emergency, and like everything is built with a calculation to provide patients comfort at the maximum level, and also to provide the whole range of medical services at one place. So in total, in our main campus, we have around 6,000 doctors and scientific workers or researchers, and we also have the personnel of, let us pay the nurses with the education, with a higher education, so they are capable of interpretation of medical results and giving some protocols. But with the big cases and big issues, they of course will reach doctors, and we have nurses around 6,000. So one of the priorities in the American medicine is to provide medical service as much as possible to nurses. For example, in the reanimation, it's like one by one. In the standard,
And so the rate will be 1 to 3. This 16,000 nurses which are working there, they should provide the maximum effectivity of the treatment that we provide in our center. How do we think to implement this great idea to improve the indicator of the treatment of children with oncological disease in Uzbekistan? This is not an easy process. Of course, it looks like an idea, undoable idea. But without the preliminary preparation, of course, nothing can be done. And one of the first steps is we need to conduct the detailed analysis of the issues related to the early detection of the oncological diseases in regions of Uzbekistan, as well as we need to conduct the analysis of difficulty to put the proper diagnosis on time. It might be conducted, and the National Tumor Board, they need to discuss certain difficult cases, if those cases are brought from the regions by doctors, and they would discuss it at the National Cancer Board, so doctors can discuss all these points and provide their opinions about that. This is the one of the approach, and it should be an approach at the national level, so the generalized taxes will be developed after that. And this kind of approach can be involved in order to discuss certain diagnostic issues or regarding the imaging or some kind of histological, some kind of uncertain scenarios where it is difficult to find what kind of neoplasia it is. In addition to that, we need to analyze the early and late complications which might affect the dynamics of the survival rate of the patient. Up to 1 year old, this might be infection complications and complications related to the toxicity of the medical medicines as well as its combination, etc. In addition to that, we need to conduct the detailed analysis of the ambulatory, the outpatient surveillance of the patients. And Dr. Palatova, she shared that regional office of WHO, they provided certain priority ideas to improve the dynamic of the indicators of ecological service in the country. Those are the main 6 groups which are shown on the slide that we want to be focused at the beginning. Of course, this is the leukosis and lymphomas, Hodgkin's lymphoma, non-Hodgkin type of lymphomas. And here we showed 3 most common histological options of the non-Hodgkin's lymphomas, Wilms tumor, retinoblastoma, as well as low differentiated neoplasms of the brain. How should we do that and implement that? If our analysis, it will bring to the results that we are expecting, then we will see that we are going towards proper direction. Then we need to form the initiative group, which will participate in the discussions of the approaches from different sides. It's important to conduct some kind of workshops for the medical staff at every level, for the doctors, for the young doctors, for the residents, for the researchers, for the nurses and clinical pharmacists. Those are the specialists that we will be based on when we will use the new protocols to be implemented. And again, we are coming back to the point that, to the details that I shared with you. Those are wonderful results of the treatment. Those are the protocols which are existing, and we will also discuss them, whether we can imply it within the conditions of the Republic of Uzbekistan. Everything is not that easy to be done, of course. Nothing can be implied based on non-certain sources. Of course, there are publications, many publications are quite accessible. One of the resources is considered a National Comprehensive Cancer Network. This is the registry of the algorithms to treat different types of oncological diseases, including the treatment of children. Those algorithms, they look like that. As an example, they explain in a stepwise fashion how to treat the patient with the standard risk of the acute leukemia. and if what to do if the patient is within the remission stage or not. All those algorithms, they exist, and the main task of our collaboration would be to implement it into the clinical practice in order to understand clearly how we should go forward in not in easy situations, and what kind of approaches to choose. Those algorithms, they exist in Russian language as well. Whatever I shown to you, this is in English language, which I just downloaded to my computer. But when we start working with you, all those beautiful algorithms, so they will be available again in Russian language, and it will be accessible for our discussions at the local level, starting from the center. Regarding the protocol of treatment, of course, I want to say that I would not say that our treatment options are the best, but I think we need to use the things, and it will be properly used, the things what are shown in the practice and gives the results of the status in cases. In the, there is some kind of institution which is called Children's Oncology, Children's Oncology Group, and it includes medical centers all over the USA, Canada, Australia. And this allows to treat patients with a certain diagnosis by standard protocols. This is what I wanted to share, how those protocols look like. In general, they show all the medicines, how do they implied, how they are implied, what is the period of treatment, and what is the period that this medicine should be injected or given, because there are certain side effects related to the non-proper use of this medicine, of course. And the doses are shown here based on the age, and also the daily doses are also shown. And those roadmaps, they are updated. They have certain annexes, such as those kind of tables, where you can show exactly the date and time when the medicine was used for a certain patient. Those roadmaps, they are existing for every cycle of the therapy, for every protocol that we are using. Why do we need that? Of course, we are using the electronic system of note-taking for every patient, but anyway, for recording of every patient, but anyway, we have this paperwork of the protocol, and we need to fill it with the pen. In case of audit happens, if the inspection comes and they request us to provide information how the patient was treated, we have all these paper files available to provide it for the inspection to discuss. Regarding the idea that we should have to discuss before we implement it, all the new protocols and the new treatment options should be, of course, approved by the Ministry of Health at the initial stage, and of course, its effectiveness and opportunities to use, capacities to be used within the head center. And after that, we will discuss how soon those new protocols will reach the regional doctors. And of course, those changes should have to be implied in every certain administrative regions of the Republic of Uzbekistan. In addition to that, we plan to create electronic library for conducting the constant, continuous education of medical specialists. This is our present to the medical center. Those are medical books on pediatric oncology, bone marrow transplantation, radiation oncology, and etc. Whatever is helpful to be read at least once in order to understand all the details and aspects of treatment. In addition to this, electronic library will consist of all the protocols, all the additional materials, all the algorithms that we will discuss will try to adapt to the realities of the medical practice of Uzbekistan. In addition to that, the whole collection of the educational materials for the patients as well as for their parents will be included. As it was discussed, it's very important to understand that children, especially if it's a patient, teenager, they need to take active participation in the discussion of their disease. They need to be informed regarding the possible prognosis, about the methods of treatment. Information should be provided in a proper way. So maybe there is not only one treatment option available for them. So, and you can also try maybe one or out of two different treatments. All this information is planned to be developed in Russian and Uzbek languages to provide it for the patients if it's needed. If they are interested in getting this information about their disease. So this library theoretically will exist, and on the base of Google iCloud, whatever is needed here is just to enter the Google account and open this book in general. Everything will be available in electronic format in every center at the territory of the Republic of Uzbekistan. In addition to that, what's important to say about the experience exchange, as you know, Dr. Polatova, she organized Onco School. This is a non-commercial center which is conducting the training for the specialists within the oncology sphere. And already there is infrastructure existing in order to conduct the webinars and lectures provided on certain hot topics. In addition to that, it is possible to organize the fellowships to the Cleveland clinics. It is important, of course, to the young specialists who will help to develop conceptual all those plans and protocols, because they will be the specialists that we will rely on in the future. And in continuation of today's topic, of course, the scientific conferences in the Republic of Uzbekistan by attending international experts will be important. This is one of the examples that we have today, actually, and witness. How do we see our success? Every success should be measured somehow, of course. And analysis, of course, will be conducted constantly on a constant base. And we will pay attention to the reduction of time from time of the first time coming to the consultation up to the putting the diagnosis, as well as those are the factors which might affect the effectivity of the treatment of patients with oncological diseases. In addition to that, reduction of the cases of acute infection complications such as sepsis, typhoid, and different pervasive infections, fungal infection, which might be a cause of certain problems. In addition to that, delays of the active chemotherapy will be measured. Of course, long-term success will be also measured, including the amount of patients which will reach the full remission, improving the quality of survival rate in the first year. I will come back to the numbers which was spoken earlier, as well as improving the 5-year survival rate is also going to be measured. All those kind of indicators that are used all over the world. One of the success rate is considered to be the state as well as non-government organization support, private charity funds. We know that today we have the representatives of WHO, maybe UNICEF, maybe they can be also involved, but I don't want to speak anything about USAID. Unfortunately, USAID is an international donor will not be the big player on the international arena, but time will show, of course. What is important is to conduct on timely basis the information exchange, and I think the experience that our colleagues from the Russian Federation has, from Armenia, this is important. International connections are very important. Everything should be used in an everyday practice in order to make the results better on a daily basis at the clinical level. We also need to remember about the good provisioning of the medicines, as well as the provisioning of the modern medical equipment, and of course the reporting accountability is important as well. I also should mention that every result should be measured and should be presented for discussion at the level of the clinical team, at the level of the Ministry of Health. And again, I think someday we will have possibility to discuss the result of the improved results of the treatment, of the updates and changes that might be implied. I want to thank Dr. Palatova for providing this opportunity to me. This is our first meeting with her, which led the beginning of our dialogue. And I think I have one more minute to respond to your questions, if you have any questions. Let's thank our honored lecturer, because in America it's night time right now, and without paying attention to this, he still presented to dear colleagues. If you have any questions regarding the possible perspectives of the collaboration among the Cleveland Clinic and Republic of Uzbekistan in order to improve the indicators of the pediatric oncological service. If you have any questions, then we are ready to get those. Can you raise your hand, please? We will provide the microphone. If there is no question, then we want to thank once more Ilya for your presentation. We hope for the future collaboration with you. Thank you once more. You too. Dear guests, we will continue. And now the next speaker will be an online format with us, and you will have possibility to ask questions if you want. Similarly, in addition to that, our moderators, they can ask their questions straight, directly to the lecturers. But here, what is important, we want you to get as much knowledge as possible. That's why we would ask you to ask questions if you have those.
Palliative care for children with cancer. Keep in touch with us. Julie Link, Technical Officer, Palliative Care Health Workforce and the Service Delivery Unit, Division of Country and Health Policy Systems, World Health Organization. Please meet.
Good morning, everybody. Let me just turn off the interpretation, because I'm hearing myself speak. Okay. Let me share. Greetings from Cyprus, where I'm presenting here at a childhood cancer conference too. I'm the Technical Officer for Palliative Care in the WHO European region, and I have a keen interest in children's palliative care. I've worked in children's palliative care in various countries, and I'm very keen that it be involved in all childhood cancer. So this is the bit where I tell you that the decision-making body of the World Health Organization is the World Health Assembly. And in 2014, they passed this landmark resolution, which was on palliative care and on strengthening palliative care throughout the world. And one of the really interesting parts of this is that they also included palliative care for children and recognised the importance of making sure that although numbers of children dying are small, that they also have a huge impact on society and on families. So it's really important that they're included in any palliative care. This document also made lots of recommendations, which I'm going to discuss further in this presentation. But for example, access to opioids is really important as part of palliative care, and that's something I want to talk about more. So what is palliative care for children? So in fact, you could probably swap oncology for palliative care for children in that it should be total care of the child, their holistic care, so not just their physical pain and symptoms and their disease, but also their psychological and social supports, and also providing support for families, which of course for all of us who are parents, we can't imagine how difficult it would be to be going through something like this. And so including the family in all parts of treatment and care, including palliative care, is really important. Palliative care should begin at the time of diagnosis. So for children with cancer, all of them will have a life-limiting or a life-threatening condition. So it's important that we think of palliative care at the very beginning and include it with diagnosis, and it can be given alongside care regardless of the child getting tumor-directed treatment as well. So it should be given alongside, and if the child recovers and their cancer is cured, then obviously palliative care isn't needed and can drop off. But if their condition means that they have a terminal diagnosis, then palliative care becomes more important and should take over care and work alongside our colleagues in oncology. Health providers should look at all the child holistically and think about their social circumstances and where they wish to be cared for. No one person can provide meet all the needs of a family, a child and family, and so it's really important to have broad multidisciplinary care. So that should be included in the care of children, that we have psychologists, nurses, really important. Many nurses in other countries would have advanced practice roles and take a very big part in caring for families, but physiotherapists, occupational therapists, to make sure that the child and family receive the support they need. And care should be provided. Palliative care can be provided anywhere. It doesn't have to be in a hospice. It can be provided in a hospital, a hospice, a tertiary care centre, and in the child's home. And in fact, it should be a seamless service between those different locations as care is needed and tailored to the child's needs. So in 2018, the Lancet Oncology suggested that palliative care and oncology improves symptoms and survival. So by integrating it early, this is how you improve care. You reduce anxiety and depression, reduce futile treatments at end of life. So it's sometimes people are treated to the very end of their life with very expensive treatments and tests and investigations, when perhaps palliative care would prevent that from happening. So it can in some cases even save costs. Improves patient and family quality of life, and also improves use of health resources, which of course is very important. So palliative care in pediatric oncology, this update from 2022 raised the following issues. So 5.2% of the palliative care needs in children are from cancer, and 90% of those live in low and middle income countries. And as Ilya was saying just in the last presentation, we know survival rates are poor in many countries, and in Uzbekistan that is the case. So therefore palliative care becomes more important. Of course, our aim is always to treat the treatable and cure where possible, but when you have very low cure rates, then there's a really important need to develop palliative care services. Children with cancer experience pain and other physical symptoms just as anyone else does, and these really need impeccable assessment. You need to assess their symptoms and treat them. And I think one of the issues I know from my visits to Uzbekistan is there are issues with access to things such as narcotics or strong opioids, which are the cornerstone of pain management in cancer. And so having access, to example, for immediate release morphine, tablets, injections, I know there are some procurement and supply issues, and I think this is something that we need to see if we can address. But certainly having access to those medicines would make the life of children and their families much better if they can access pain and also for other symptoms as well. For example, morphine is very good for breathlessness, dyspnea, and so having a range of those drugs which are included on the WHO list of essential medicines for palliative care in children, and having those available would make a big difference. The burden on families is huge. So if an adult gets cancer, quite often their family are able to find people to look after them. But when you're a young parents and you have other children, obviously it's very hard to care for the child's siblings and to be in hospital and care for your sick child. So families' burden is really huge. And also they need help with being able to provide care themselves and being shown how to care for their child, how to manage their medications and so on. So that's a really important role of the multidisciplinary team in palliative care. So often, and in this paper, they found that referrals to palliative care are rare and late, and that oncologists and hematologists gatekeep. So that just means that they hold on to the children and don't refer to palliative care services. What I would say is in Uzbekistan, palliative care is in its infancy, and maybe you don't have the ability to be able to refer to palliative care at this time, only to Tashkent Children's Hospital and to my dear friend Rustam at Nurbayev, and you know that really, other than that, palliative care is developing but hasn't got there yet. Increased knowledge about palliative care is really helpful. So if people understand the principles and practices, and ideally palliative care should be included in the education and training of all healthcare professionals. And so right from that early stage, that you understand the principles of caring, the holistic, multidisciplinary nature of caring in palliative care, but also giving you much better understanding of, the pain and symptom management, and having the knowledge and skills to be able to manage that if palliative care are included in education and training. So this is some data from the European Atlas of Palliative Care. So this was taken from 2019. I'm very pleased to tell you that the next edition of this atlas will be launched in May this year. So the data has already been collected, and I thank anyone in Uzbekistan who helped to provide that information. But you can see that 20 countries have specialist consultants in pediatric palliative care. Perinatal palliative care is huge and a growing area, and 7 countries were able to say they had that. But it's around where care is provided. You can see at the bottom here, in the Netherlands, a lot of care is provided in the community rather than in hospitals, and that children's palliative care has really well developed in many Western European countries. But in low and middle income countries, this paper was taken and using the data from the Atlas, in low and middle income countries, it was really clear that palliative care for children was less available, and that actually this is often where it's needed most. If you think back to the slide where 90% of children who require palliative care live in low and middle income countries, and yet that's the place where palliative care is least developed. So the advances and challenges. So this is a paper from 2020, and what this paper found was that there's no evidence about decision making and communication and symptom management. Children's palliative care is a relatively new specialty in many countries. It's much less advanced than adult palliative care, and so we need the evidence from caring for children, and this is something that became very clear. We need high quality data, and I know in Uzbekistan you're starting to collect. You have a national cancer registry just starting, and that information should become available, but certainly the higher the quality of that data, the better for the development of services. It's still not clear what the best way to care is or the place of care. Many children, despite wanting to die at home, many still die in hospices and hospitals, and I know in Uzbekistan, it's if a child is thought to be dying, then often they would go home to die, but then we need to have the services in place to help support families to provide that care at home. And advanced care planning has really been something that's been studied extensively in Western Europe and other Western countries, looking at asking where do people want to be and making a plan and making sure that people can be where they want to be and spend their last days, weeks, months in the way they best would like to. So advanced care planning for children obviously is quite a contentious issue because having to have that conversation with parents can be very challenging. And I think this is where palliative care plays a really important role. So there are standards for paediatric palliative care in Europe. This is the original version, which were formed in 2005, and there is now, in that, there was a definition of children's palliative care, defining which children need palliative care, needs assessments, and looking at a range of needs assessments that have been conducted in children's palliative care, which usually come up with very similar results, and that's around looking after children at home and making sure you have the services available, and that's where most parents, if asked, would like to care for their child. Education and training is key, and obviously making sure that people understand what palliative care is really important, but also for people, clinicians' confidence. And so, for example, I'm going to talk about that later when we look at some of the results from the St. Jude study. And also having standards of care, and that there are similarities in the development of children's palliative care. So whilst Uzbekistan is in the very early stages of development, it's a well-trodden path. Other countries have been there, and there is so much you can learn from what's happened in other countries. So there's some new standards which you can find very easily, and they really look again and give even more detail about what paediatric palliative care is and who it is for. And I should say, although this is a childhood cancer conference, in many countries, the majority of children cared for in palliative care are not those with cancer. They're more children with other conditions, genetic conditions, and global developmental delay and other conditions. But certainly these are applicable to childhood cancer too. The European Association for Palliative Care developed a charter on what families should expect and the standards, and that's very easily available. It's also available in Russian if you want to look it up, and it's on the European Association website. In addition, the World Health Organization has several documents that are key to children's palliative care and looking at how we should integrate palliative care into pediatrics for oncology and for other conditions. There's also the list of essential medicines that I spoke about earlier, which talks about which medicines should be available for children's palliative care. And then there's also these very, very helpful guidelines on managing pain in children. So just some data from Uzbekistan from the 2019 ADAPT study from St. Jude, and they looked at 11 countries in Eurasia, and I just thought some of these would be very interesting for you to see, that when they had a 55% or 50% response rate from Uzbekistan, and that doctors were saying that they have no access to palliative care, that they can't have consultations, and that often if palliative care was involved, it was often too late in the treatment of the child. In addition, you can see here that the barriers to palliative care were that there was a lack of home care services. And certainly when I was in Uzbekistan 2 weeks ago, I was talking to the chief nurse in Uzbekistan, and we were talking about how perhaps we could look at supporting families more in terms of nursing support at home. So there's limited access to palliative care, families' resistance. Again, culturally, if people don't talk about palliative care or talk openly about death and dying, and this can be very challenging, and culturally everyone's different, each culture is very different, and obviously that's something that has to be taken into consideration. So physicians felt they had limited knowledge, and also they felt uncomfortable talking about palliative care. So I think we've got some good starting data. So in delivering palliative care, and I think these are some of the key issues. So 60% of doctors felt that they they felt uncomfortable. They didn't feel comfortable about treating children's physical symptoms and their emotional needs. Emotional bereavement support wasn't provided, and they felt, I think this is quite sad, that doctors felt burdened by their inability to control the suffering of children at end of life. And there is so much that can be done. And in fact, we all have this saying in palliative care that there's never nothing more that can be done. We always find something that we can help manage pain, symptoms, and again, looking at the child holistically and the family holistically, there's always something that can be done. So how do we improve palliative care? And this is my last but one slide. So how do we improve palliative care? So this is the WHO public health model for palliative care. So you can see the foundations of the house is that we need to get communities and people talking about palliative care and death and dying. And this has happened quite successfully in some countries. And this is in countries where perhaps culturally, again, it wouldn't be appropriate to talk about death and dying, that we're starting to move that dial so that people start to talk about, well, what would I want if I was dying? And this is something that we need to get more comfortable with. We need to make sure that palliative care is included in all health policies. So not just in cancer policies and in a policy on its own, but in policies for other conditions and other healthcare professionals, so for nurses, for doctors, any policy, we should have palliative care, education and training. We need to know that palliative care is included in policies at a national level. We also need research. We need good data. We need to know where people are dying and know their age. We need to have good national data, but we also need good data when we set up services. And in cancer, we need to have that too, so that we know where people are, and we have this so that we can plan services for the future. Access to essential medicines, my third time mentioning it, but it is a really important issue. And also, I think that goes hand in hand with the other pillar of the house, where you have to see that education and training is so important. So they go hand in hand. People are worried about prescribing strong opioids and other drugs for pain and symptom management. It's much easier to prescribe drugs that aren't as good. So, for example, tramadol has a ceiling dose, but people prescribe it because there's not as many restrictions on prescribing. In Russia, they have moved a long way with legislation and decriminalizing the medical prescribing of morphine and other narcotics. And so I think it can be done, and we're working very closely with Russia, and certainly it's something that I think we can look at how that happened there, so that we can learn the lessons from that. Education and training for all your healthcare professionals is really important. And if we truly want to have integrated palliative care that meets the needs of patients and their families, then we really need to look at this model and think about how we can develop palliative care services. So just in summary, palliative care needs to be integrated into the care of children with cancer from the time of diagnosis. It can be given alongside treatment aimed at cure. Palliative care can often add something, even if the aim of treatment is cure. Palliative care can still add with pain, symptom management, some of the psychosocial support and so on. We need to increase awareness about paediatric palliative care because it makes such a difference. And there is really strong evidence that palliative care improves pain and symptom management and improves quality of life for children and for their families. And so I'd like to thank you for listening, and wishing you a very good conference. I wish I was there with you. So thank you.
Thanks for the great performance, Dr. Ling. And we hope to see you at the conference next.
It would be great.
Albatta, kattakon rahmat deb xayrlashga majbur.
Unfortunately, we didn't have time to ask questions because we are going out of the time frames, and that's why we will give the floor to the next speaker now, and we will ask the next speaker to follow the time frames. And that's why we don't have time for asking questions to Dr. Ling, due to the fact that we are a bit late now from the time frames. That's why I want to remind that every speaker has only 15 minutes to speak. And now the next topic is organization of oncohematological and hematological service in pediatric oncohematology in Azerbaijan Republic. The floor is given to Zuhra Ali Mirzaeva. She is the Deputy Director of the National Center of Hematology and Transfusiology. The floor is yours. Dear colleagues, dear friends, I want to thank organizers, Ms. Jamila Hanum, for the invitation, and for providing us possibility to give a presentation today in front of you. I want to send our greetings to your respected minister, and I want you to tell you about the Organization of Oncohematology and Hematology Service Pediatric Population in Azerbaijan. Our children who are having the oncohematological and hematological diseases, they receive the treatment within the National Center of Hematology and Transfusiology, which is located, which consists of two departments. One is hematology department. It includes outpatient, inpatient, as well as ICU unit, and pediatric departments as well, and it includes laboratory, outpatient, and radiological departments. And there is another thalassemia big facility, which includes outpatient clinic, inpatient clinic, laboratory with the modern equipment for the diagnosis of thalassemia to be done, and the bone marrow transplantation department, as well as prophylactic of thalassemia department. And in addition to that, we have hematological divisions within the Republican Center as well. The Department of and Scientific Practical Center of Hemophilia is located under the facility continuous education of the doctors, and they all children, they receive plasma factors, and based on that, the registry of children with hemophilia is created. Within the central hospital, we have hematological offices available. There are certain laws which are approved, as the state programs are approved on pediatric oncohematology. Those are the next laws of Azerbaijan Republic, of the state support of children with the inherited diseases, as well as those who have hemophilia and thalassemia, etc. There are also state programs which are adopted to develop the donorship, as well as the blood service, the state program on combating thalassemia, as well as a state program to combat the malignant blood diseases. And based on that, all children, they receive free of charge medical services by this program, based on this program. The Pediatric Hematology Department has 23 beds, each of which is equipped with modern equipment, such as oxygen panel to support respiratory function, HEPA filtration to improve air quality and prevent infections, a separate bathroom to ensure sanitary standards and patient control. I also want to show you the statistics of acute leukemia incidence among children in Azerbaijan. Here you can see the amount of patients sick, and currently we have 316 patients with acute lymphoblastic leukosis, as well as 52 with acute myeloblastic leukosis. All patients, they receive, they conduct in the genetic testing, and all the genetic abnormalities are revealed if they have leukosis. Diagnosis and monitoring is conducted for the patient with the so what kind of We have flow cytometry and flow MRD for detailed analysis of the cellular composition of the blood, ALL and AML FISH panels for detection of genetic abnormalities, molecular genetic analysis to clarify the individual prognosis and select therapy. Each diagnostic panel analyzes 12 routine mutations. After induction and consolidation of treatment, flow MRD and genetic testing are performed to monitor and assess the effectiveness of the therapy. This is our laboratory, cytogenetic laboratory, molecular cytogenetic laboratory, as well as molecular genetics laboratory. Here we conduct all the necessary analysis to diagnose and monitor the treatment. We are using the modern protocols in order to treat our patients with acute leukosis. For the acute lymphoblastic leukosis within our clinic, we use a protocol which is called AALL BFM 2022. AIEOP BFM 2017 as well as MB 2015. The protocols for the AML is AML 2019 and APL 2019. For the relapsed AML patients, we apply the BFM as well as recently we start to use venetoclax and azacitidine. From 2024, ALL relapse has been implemented, which was improved the effectiveness of relapse therapy. Joining the working group of ALL BFM 2024 facilitates the exchange of experience and the improvement of clinical outcomes. Here I want to show the general survival rate of our patients, overall survival rate in LL 87%, event-free survival is 72%. In TALL, overall survival rate is 82%, and event-free survival 69%. And in myeloblastic leukosis, overall survival rate is 71%, event-free survival is 53%. Taking into account that the thalassemia is an inherited hematological disease, which is spread in our republic, 9 to 12% of the population is considered to be the carrier of this disease. I want to shortly explain about the project to combat against the thalassemia. 20 years ago, we had a round table with the project of the Heydar Aliyev Foundation in the name of the Life Without Thalassemia. The initiator of this project is our First Lady as well as the President. She's the president of this fund, Heydar Aliyev, Mihriban Aliyeva. She discussed all the problems related to the thalassemia and the treatment options. After that, the state laws were adopted in 2009, 9th of May. The first Republican Center of Thalassemia was opened, and all the patients of our republic who had thalassemia, they received within the center high effective treatment. And we conduct radical methods of treatment, such as bone marrow transplantation. If many years ago, those patients were not surviving up to the teenage age, and now they can survive up to adult age, and they study within the university, they work among us, they create families, and they have even healthy children nowadays. And the program of control of thalassemia, it includes the treatment, educational assistant, healing assistant, such as blood transfusion, removal of excess iron, splenectomy, bone marrow transplantation, and etc. We also provide the psychosocial support, and the main point is that in our republic we have the preventing standards for thalassemia. All the young people who are marrying, they have to conduct in obligatory way the medical check. In order to prevent thalassemia, we should conduct the awareness raising among the population, and that we are doing. We also try to conduct the medical genetic consulting as well as prenatal diagnosis. In addition to that, the training of the staff is also within this program. Involving this population who has thalassemia, etc. I also want to provide you information about the results. We are using the modern research methods to conduct the diagnosis of thalassemia. We are using high-performance liquid chromatography, capillary electrophoresis, PCR diagnostics, next-generation sequencing. Patients with thalassemia are fully provided with high-quality and safe red blood cell mass, freed from leukocytes, filtration in the blood bank. To ensure compatibility of donor blood with the blood of thalassemic patients, the following is carried out: cross-match typing by minor erythrocyte antigens. Chelation therapy is carried out using all currently existing iron-removing drugs in the form of mono combination therapy. Since 2014, patients with a comparable donor have been undergoing bone marrow transplantation. I want to say that we are taking the donors from the relatives to conduct a bone marrow transplantation. Since 2015, a state program to prevent the birth of children with thalassemia has been implemented, including carrier screening, medical genetic consultation, and prenatal diagnostics. We created the registry of all the patients who are having thalassemia, including 3,062 patients. It includes beta thalassemia major, intermediate thalassemia minor, CB thalassemia, as well as other hemoglobinopathies. All patients, based on the age categories, they have transfusion of the donor blood. And the donor blood is taken from the blood bank, and we are doing the cross match as well as erythrocyte antigens are checked. All the chelation medications are accessible for the patients with thalassemia, and we are conducting the monotherapy as well as combined therapy. The transplantation of the bone marrow, allogeneic bone marrow transplantation for thalassemia patients began in May 2014. Up till now, 189 transplantation is done. 153 patients are survived after the transplantation. To date, and world averages are showing that 90% of patients they survive, 80% of patients get rid of the disease fully. I want to show the transplantation of the bone marrow of our oncohematological patients. It includes 33 patients, and all the results are quite makes us happy. This is the program of the prevention of thalassemia, as I mentioned. We are conducting the screening test by hematological analyzer, CISMAX, and we conduct the confirmatory test, capillary electrophoresis, as well as medical genetic counseling and prenatal diagnostics is done. Out of 800,000 persons entering into marriage were screened for thalassemia carriage, and 31,000 were identified as carriers of the beta-thalassemia gene. In 456 couples, both members of the couples were found to be carriers of the thalassemia gene. 445 prenatal diagnoses were made. 102 fetuses were homozygous, 92 without the pathological thalassemia gene, and 250 were heterozygotes. The results of the prophylactic prevention of thalassemia is making us happy. For the whole period, the amount of patients who are born from thalassemia parents reduced up to 40 from 170. So our main goal is to reach the minimum of these non-healthy children. Thank you for your attention. We want to thank you You mentioned very important things within your presentation related to the hereditary factors. It is important not only for the medical staff as well as for us, for mass media representatives. You mentioned properly that through the inheritance, they could reveal the blood issues, and this is a great thing because every analysis and every test is very expensive, and based on the big budgets, those tests are conducted, and that shows that the state is very paying attention to reveal those diseases through their testing system, as well as in our country. We are also paying attention to that. And now we will continue. Now we have the next topic. Childhood cancer in India, current practice and future direction. The floor is given to Dr. Abhishek Shankar. He is the docent, professor assistant of the radiation oncology department of certain institute.
Just come here. You have put the wrong slide. I need your help. It's a wrong slide. It's a wrong slide.
Navbatdagi doklad egasiga savollaringiz bo'lsa, albatta keyin bemalol berishingiz.
If you have questions to the future speakers, so you can ask questions if you are interested in. I should have to mention about the time frame that every speaker has only 15 minutes available.
Just open this.
Хотели бы передать слово нашим волонтерам.
We would like to tell to our volunteers, don't turn on. We have here online connection.
This is not, come here, this is not my slide. I have the another slides, okay? So which, this is not my
Yana bir bor eslatib o'tamiz. Savollaringizni tayyorlab qo'yishingiz mumkin.
We want to repeat again, saying that you can prepare your questions, and every speaker has only 15 minutes.
Where is, just open it, USB. Just let me open it. Oh yeah, this is my slide.
Okay, let's start.
Yeah, done. Okay. Thank you so much, organizer, for this opportunity. And I'm sorry for this disturbance for a while. First of all, happy Valentine's Day to everyone. And I think what a greater day it will be that all the people on Valentine's Day is just talking about the children's health, because I personally think this is the best way to celebrate Valentine's Day, because children are the most adorable and the most lovely creature in this world. So thank you for this opportunity to allow me to celebrate Valentine's Day by talking about the children. So I will be very brief, and I think I will be on time. So I don't have any financial relevant disclosure, and probably in the era of AI, where people are leveled to use, ChatGPT or another AI tools for making the presentation, I just want to disclose that I have not used ChatGPT or any other AI tools for making this presentation. So global burden of childhood cancer, you have already learned so much about this. So childhood cancer ranks 9th in the leading cause. And when we talk about the disease-adjusted life years, it affects too much. 80% of the children at risk of childhood cancer resides in low and middle income country, and that's too bad for us, because in view of the facilities we have, the survival rates are not so good. So, in high-income country, the 5-year survival is more than 80%. In India, where I work, survival is close to the Western world, but I should not celebrate this because there is so much of disparity and inequality in access to care and the outcome. So low survival rate in all the LMICs is attributed to weak infrastructure, lack of supportive care, and poorly defined care pathway. You don't know what is the first step to the last step, and many children present with advanced stages, and when you see the patient of cancer in advanced stages, the survival is very, very bad. So childhood cancer in India, it is 0 to 14 years we level at, and 4% of all cancers. Highest age attributed incidence rate is in Delhi, where I live, in terms of female and male, both as per the population-based cancer registry. So disease-adjusted life years are mainly more with the cancers of eye and the lymphoid leukemia. So Government of India has, started implementing program for NCD, but there is no specific program in relation to the childhood cancer. And in my personal opinion, I don't see childhood cancer much, but in my personal opinion, there should be a spotlight why children with the diverse background should die of childhood cancer, because you are not giving them proper, facility to survive them from cancer. So most studies in India or as part of the world has been done in the selected geographical setting. So we need to have data which represents the whole country, not to specific. So childhood cancer in India, this was one paper which showed that national number of children 0 to 14 years and adolescent 0 to 19 years, they have said that there is an increase in number every year, and they have just stipulated over the period of time what will be the number, which is very alarming. And you see the death part, which is again increasing in number every year. So we have, how do we treat cancer in India? There are tertiary care hospitals where in the medical college, super specialty, multi-speciality, and the secondary level hospital where we have, hospital which has some pediatrician who is treating childhood cancer. So this is from our center, childhood cancer in India. And I think as far as childhood cancer is concerned, India has made a significant improvement in outcomes, but still we have a large barrier because I said there is a diversity and there is a disparity in inequality. Until and unless you just cover up with that, it is very, very difficult to make patients survive. I will just come to the number of oncologists, number of hospitals in different parts. So tertiary hospital that I define, a dedicated pediatric department is available in only 41.6% of the public hospital, 48.6% of the private hospital. And as this is related to the childhood cancer, many of the NGOs has come forward to start a hospital to give services to the children with pediatric cancer. So pediatric oncology, which is one, very, very highly focused oncology specialty, it's growing in number, but still it is a 48% of the public hospital has a pediatric oncologist, 44.3% of the private and NGO managed hospital, the maximum 64% has a pediatric oncologist. So treatment through general pediatric medicine, you can see 77%, pediatric surgery 62%. So these are the specialty. Apart from pediatric oncologists, they manage the cancer, children with cancer. So nurses trained in pediatric oncology, you can see this is very sparse, and ultimately you can see the hospital which is managed by NGO for the treatment of pediatric cancer. They have a better equipped with a pediatric oncologist, nurses who has been trained in pediatric. So tertiary hospital cancer treatment, have blood bank and all this thing, tertiary hospital, you have it. But if you talk about the other alternative thing like play therapy, hospice care, less than 1/3 of the hospital have it. Over 2/3 of the government tertiary hospital have a referral linkages. It is very, very important to have a referral linkages because most of the hospital is not giving the full proof services. So you should have a referral linkages and you should have a to see the compliance of the patient, because most of the patient come from the rural background. Once surgery is done, they don't understand after this, the treatment is not over. They have to go for the, adjuvant therapy, and they leave the treatment in between. So that compliance is very important. So secondary hospitals, provided in 36 of the 90 hospitals in the country. This is mostly NGO managed hospital. Pediatric medicine department manages childhood cancer in 70% of the secondary hospital. So pediatrician is the first point of contact, and over the period of time, this is very, very necessary to teach them about the more basic things about the pediatric oncology practice. Otherwise, because of lack of awareness on the part of the doctor, can lead to the devastating effect on the outcome of the pediatric patient. So this is another WHO says that WHO Global Initiative on Childhood Cancer aims to reach at least 60% survival rate for children with cancer by 2030, and it is a long way to go in most of the LMICs. Maybe few centers are able to achieve this, maybe more than this, but we need the country representation in more comprehensive way. So diagnostic facility, 90% of the tertiary care center have a histopathology diagnosis, but if you see the secondary hospital, they have a very limited, basic laboratory and the radiological investigation, and they have to have a refer to the higher center for the diagnosis and the further treatment. So cancer treatment drugs, although I know that most of the drugs are cheaper, so tertiary hospitals, 50% of the public tertiary hospitals have the stocks. When it comes to the secondary hospitals, they have sufficient stock for the routine chemotherapy drugs when they have to manage the side effects, because pediatric cancer is a resource intense process, and when you have to manage the side effects, not only to the cancers, and side effects related to the drugs are very, very, sometimes very difficult to manage the side effects of the drug. This is the chart. I'm showing the availability of childhood cancer treating drugs in tertiary hospital and divided into the NGO, private and the public. This is another chart which is showing the cost of this. Either it's a free, subsidized, or the market rate. You can see the distribution, and you can find most of the public hospital in India just give free treatment or a few of the advanced drugs as the subsidized rates. So this is for the primary, secondary level public hospital and the private hospital, and you can see that private hospital has a better stock of the drug, and they are not struggling with the stock issue, which is always a problem in the public hospital. So physical infrastructure, less than 50% of the public tertiary hospital had a separate room for managing children, but it's like a dream come true that you see a dedicated pediatric cancer hospital, which you now see a dedicated cancer hospital, but we should have a different wing of this. So this is infrastructure comparison, capacity building. It's a big task for most of the LMICs. The good people, if they learn so good, they go to abroad and just settle there. So it's a very difficult to manage with the human resources angle. So this is the distribution of pediatric oncology training courses in tertiary hospitals in India. And I think COVID-19 has impacted the progress in terms of pediatric oncology progress to a larger extent, and probably it really halted the progress, and we will take much more time to compensate the loss of time during those periods. So this is impact in different forms. So situational analysis of the childhood cancer services, this is a policy brief, and you can see that what we have devised, there is a gap in the availability of the pediatric oncologist. Department is, advanced diagnostic, dedicated beds, and most of the time in our hospital, children are just struggling to get a bed to just continue with the treatment. So this is an ideal pediatric oncology unit, but nothing is ideal in this world. So we'll have to wait for the next life to see the ideal situation in everything, including the pediatric cancer care. So way forward is, universal health coverage is an important agenda. Whole government is trying to just figure out how to just give maximum services to this. And I personally advocate this should be done in the pediatric cancer care. Integration of childhood cancer program in different scheme. There should be a national childhood cancer policy. SARE care model is the best thing. And you should have, whenever you have a national cancer control program or national cancer control scheme in your country, pediatric cancer care should be given a different mention and should be highlighted. It should be a spotlight in any of the program, which is not happening right now. So dream ideas, what we can do. Dream is always a dream. we can just leave it here. So role of government policies and intervention, role of technology and innovation, mobilizing community involvement, addressing health inequalities is a big thing. Disparity and inequality, we just read it, we just forget it, we just don't try to level the field for each and everyone. We should have a collaboration. Strengthening health system, economic and social benefits is too much, because you don't want young children to die because of cancer. It have a bigger impact on your workforce in the country. These are the challenges that we have in India. Most is the rapidly expanding population. Many of the people talk about we should do something like Australia, we should do something like New Zealand. So as a countryman, I'm very proud that India add one Australia to his population every year. So we should not talk about those countries. So this is a strategic roadmap, need assessment and planning, stakeholder engagement, infrastructure development and implementation, which is a very, very difficult phase, and we are working on few projects in the implementation science, which is a newer science, and every LMICs must focus on the implementation phase, which until and unless you will never get the implementation efficacy. And operation management is an important scheme when you have the resources, how to utilize those available resources to set your goals and to achieve those. This is the implementation framework, government and monitoring. This is an inspiring vision we have just created for the Asia Pacific Oncology Alliance. Although this is a very futuristic, I don't know how much you're going to get out of it, but this is the future where we see this. So I think action points, communication is very important. It is not only from the doctors to the patient, but at the national level, patient and their parents should be well aware about the treatment, their side effects, signs and symptoms, childhood cancer care institution, how it reached to the community. This is very important, training and educational, standard treatment guideline, which is very important. Every time when you see NCCN and you see your resources, this is not matching at all, so you need to work in between. And now NCCN has come up with the harmonized guideline they have created for Africa. We are working on some similar kind of things in India, leveraging the insurance scheme that we have in India, and probably for every children, whether they're with cancer or not cancer, probably they must go for vaccination, which is I would like to. So we need to act against all odds to improve odds, because as a social being, as a human being, we have become very, very personalized, and we are trying to manage cancer with our self-centric approach, which is not possible. We need to work on all the socio-cultural determinants, and probably we need to come up with the community and the population-based participation if we want to improve odds against all odds. So this is my take-home message that is already clear. So this is my last slide. I always say that if you want to be ill, you should not talk in terms of I, me, and myself, because the critical letter of illness is I. If you want to promote wellness and want to be well throughout your life, you should talk about we. So this is the best approach. Somebody can adopt it. And I think I would like to just, one video which is not here. Okay. Yes. So this is a video. I was just trying to play it. You can see this is all about childhood cancer. I'm so impressed with the video because that teaches you so many things. You just see this, you will learn a lot, more than my lecture, more than my lecture. It's not working. Can somebody help me in playing Animal Tutorials? thank you so much for watching this. I think this is so much of learning from this video. I have learned that we just make so much hue and cry that I don't have this, I don't have that. But just see if you have a right intention and you are willing to do something, even a height of few hundred meters with limited resources, you can make someone happy like this. So thank you so much. If you have any question, I will be happy to answer.
Biz ham o'z navbatida katta minnat.
At the same time, we want to thank, because it was a very, even though there is a very difficult topic, but at the end we can see the smiles of children, and this is a beautiful thing, and that's why we want to thank you for that presentation. And now we will proceed, and now the next topic is the relevance of the early diagnosis as well as the therapy of the early immunodeficiencies in pediatric oncology. The head of the laboratory, the fundamental immunology department, the Republic of Uzbekistan, Ismailova Dalat Abdurahimovna, the floor is yours. I think we could connect you to our platform. Thank you. I want to give the presentation about the orphan diseases in children, actual problems and the possibilities to solve that. Orphan disease, they are considered to be the indicator of the effectiveness of the healthcare system within the country. And that's why those are considered to be the progressive diseases, and early diagnosis and treatment can preserve a person's relatively healthy status, full life, and ensure quality of life. Untimely alertness and delay in treatment leads to irreversible disability of the patient, with an additional burden on the patient's budget as well as the budget system of the country. That's why late diagnosis is catastrophic in rare diseases. Today, as of today, there are a lot of publications within the world related to the research done for the orphan diseases regarding the epidemiological conditions. And what is interesting is that more than 7,000 different rare orphan diseases are revealed, and it is considered that within the world statistics, out of 10 people within the planet, they have some kind of one type of rare disease. Here you can see the numbers. The numbers are very interesting, and of course it lets us to think about what is happening within the world and what we expect in the future. One of the biggest group of the orphan diseases is considered to be the innate immune errors, or IADs, are heterogeneous group of genetically determined disease of the immune system caused by insufficient efficiency, absence of hyperstimulation of immune factors, clinically manifested by chronic or recurrent infections, autoimmune neoplastic diseases, as well as allergic diseases. That's why the late diagnosis leads to irreversible disability, even to an unfavorable outcome. Timely diagnosis and treatment can save life and ensure quality of life of the patient. That's why I should mention that late diagnosis is catastrophic. And of course, what do we need to pay attention to when we talk about the pediatric oncology? When we mean the immunity disorders, immune deficiencies, they predispose to oncological diseases in childhood. Increasing life expectancy in immunodeficiencies patients increases the overall risk of developing cancer. The incidence of cancer, leukemia or lymphoma, solid tumors in patients with primary immunodeficiency is 1,000 times higher than in the population of healthy children. The type of malignant neoplasm depends on the type of immunodeficiency, the patient's age, and possible viral infections, and different pathogenic mechanisms are involved. Non-Hodgkin lymphomas predominate, accounting for almost 20% of cases. We also need to pay attention that what kind of immunodeficiencies are bring it to the neoplasms in pediatric population. Those are the immunoglobulin A deficiency and other DNA repair disorders are associated with an increased incidence of malignant neoplasms. What do we know for today about the primary immunodeficiency? It is so that people, we know about it a lot, but it is still a global problem, not only in Asia, in the Eastern country, but also in the whole world, in Europe, in the US, in the Northern Europe, Russia, and among all the continents there. Also try to know about it. The problem is still existing, and it's a global problem. The incidence of PID worldwide averages depending on the form and region, and it occurs more often than is commonly believed. That's why healthcare systems all over the world, they they are missing those patients. That's why early diagnosis is problematic nowadays. Within the ICD, there are more than 100 nosologies. More than 1,000 gene defects have been identified. If detected early, some forms of PID are treatable and curable. And so this is important thing to pay attention to. Those are considered to be the main groups of orphan diseases. There are certain publications there where immunologists, where pediatricians, they say that immune deficiencies, they will come out from the orphan diseases in near future. What are the prognosis for immune deficiencies? Based on the type of immune deficiency, of course, varies greatly depending on the type of immune deficits. Infants with combined immunodeficiency die in the first year of life without therapy of BMT. Thanks to improvement in treatment methods and the expansion of radical treatment options, patient outcomes and long-term survival rate have improved dramatically in children. As of today, what do we need to pay attention? The clinicians should have to pay attention to the severe conditions, whether it's infectious, hematological, oncological disease. If it's a severe, persistent, some kind of disease, then we need to pay attention to. When we talk about the immune deficiencies, so there are certain immune deficiencies that are existing within the literature which can be connected to neoplasms, such as Bloom's syndrome, ataxia-telangiectasia, as well as Nijmegen syndrome. And as I already mentioned, those immune deficiencies will bring to the neoplasms, Wiskott-Aldrich syndrome, Louis Barren, etc. Again, the International Society, they ask to pay attention to the pediatric service of the country, especially the hematological service for the diagnoses which can be a clinical mask of the congenital immune deficiencies, such as ataxia-telangiectasia, Wiskott-Aldrich syndrome, HPV-connected neoplasms, lymphomas, leukoplakia, liver cancer, Kaposi sarcoma, and etc. In pediatric population, they can be seen quite often. All those patients should be sent to be tested in order to check whether they have any immune deficiencies or not. When we talk about the hematological disease, we need to pay attention to every child with aplastic anemia, autoimmune cytopenia, inherited asplenia, thrombocytopenia, hemolytic anemia, lymphohistiocytosis, erythroid aplasia. Those are all children who are not treated by standard therapy protocols, and they give their disease is not treated properly. And here we need to think maybe there is some kind of primary immune deficiency within it. Of course, there are certain type of splenomegaly, idiopathic, all the lymphoma types, and etc. All of this nosologists are added nowadays. Here you can see all the genetic mutations which are uh, shown within this disease, such as neutropenia and etc. Uzbekistan is located in Central Asia, and this is the country which has high birth rate, and we have close to 1 million children per year. Even though there is a social improvement, we still have increased pediatric death lethality cases, and we need to think about that it's not only infectious disease but also oncohematological diseases, and that's why we need to start doing the research regarding the immune deficiency within these children, such as primary as well as the congenital immune deficiency. Those are the main laboratory tests that we need to pay attention to, and those are not the expensive ones. And within the center in our country, we are actively conducting the work in pediatric service to implement the research of conducting the qualitative and determination of the detailed blood formula. The qualitative and percentage indicators of lymphocytes are especially important. Determination of levels of immunoglobulins, molecular tests as well that are widely done in Uzbekistan nowadays, and that's why we have certain instruments in order to put the diagnosis on time and treat on time. The immune deficiencies, they might be, of course, treated, or there might be effect of the treatment if you diagnose this on time and treat it on time. This is the program which is actively involved within our clinical base in our country. And what is, of course, needed? Physical checks, examination, general clinical examination data, preliminary diagnosis, immunological examination, diagnosis verification, molecular genetic testing should be done in order to put the final diagnosis. But due to the fact that we are presenting Asia, we want to say that in Uzbekistan and in general in Central Asia, there is a polymorphism of genes, and we have a lot of marriages related to relatives, and that's why we might have different new genetic mutations, new types of congenital immunodeficiencies that we are facing first time in the world, and those mutations should be comply with the clinical symptoms. Regarding the therapy, as of today, we have the possibility to conduct the supportive therapy with immunoglobulin, such as IV or subcutaneously. We can do the antibiotic prophylaxis, all the treatment which are shown within international protocols to treat immunodeficiencies. And of course, there are certain problems and challenges related to the low detection of these patients, and I should say that this is not only our problem, this is the problem related to the whole world. Thank you so much for your attention. I finished my presentation. I want to say that the symbol of children who has primary immune deficiency is considered to be the zebra. Why zebra? Because this animal was chosen as a symbol of orphatic disease because not everyone can everyone can be on guard or put the alertness in order to reveal the diagnosis of the congenital immune deficiency. Everything is, of course, under the development. We are working actively on that. I hope based on the laws and the legislation based on our which are adopted in our country, the methods and diagnostic tools that we are using in order to reveal it, it gives certain results. Thank you so much for your attention. Thank you, Adalat Rahimovna, for the very good presentation given to us, and we wish you all the best in your career. Thank you so much. Thank you. And we will proceed. We have the next topic. Achievement and perspectives of the development of the pediatric hematology within the federal budgetary facility of the National Medical Research Center of Hematology, Oncology, and Immunology, named after Dmitry Rychakov from the Russian Federation. And we ask the deputy of the general director of the treatment service, the head physician, Dmitry Vitalyich Litvinov. We would ask him to come to the floor. Good day, dear colleagues. First of all, I want to thank organizers for the invitation. This is a very interesting conference, and I think this is very helpful for each of us. I understand the timing is violated, of course, and that's why I want to speed up. I will not tell about our clinic. I will just tell that we have 500 beds available, our inpatient clinics as well as a rehabilitation one, and a big facility which has many educational as well as scientific clinical divisions in it. For 12 certain years of we have more than 1,800 hospitalization. We have unique patients, and we conducted we have primary patients that we review. I would like to go back a bit. 35 years ago, in 1990s, February, there was a congress, and where within this congress, pediatric oncologists, hematologists from Soviet Union as well as foreign countries, they came and they made a very unique opening based on the president Alexander Grigorьevich Rumentsev. They found that in acute lymphoblastic leukosis, lymphomas, survival rate is 77%, but our foreign 17% only, but our foreign colleagues, they prevailed 70% at that time. We will not stop on the causes, but now we understand that everything was related to the fact that we had loss of the diagnostic base as well as the understanding of the standardized protocol treatment, not conducting the multicentral trials, and etc. There was a very high lethality rate. And in front of us, there were tasks to do something. And in 1991, the Scientific Research Institute was created. At the same time, our colleagues, they went through the big route. And I should have to say, none of the new chemo medicine is created for the period of for about 35 years. Everything is conducted based on the multicentral trials made. The group was created in our country as well, in our Institute of Pediatric Hematology that I am presenting today. The multicenter group Moscow Berlin was created, and we made the first protocol, and now we are living on the protocol of Moscow Berlin 2024. The big work was conducted to coordinate all the activities, and now currently more than 60 clinics they have representative from the whole Russia, Uzbekistan, and Belarus, etc. In addition to creation of the protocols, we could reach a very good result. We reduced threefold the lethality cases among pediatric population who are having cancer. This is the slide that was shown within the presentation of Alexander Grigorievich, which shows the dramatic reduction of the results. Intermediary results are like that. I'm saying that at the end of February there would be the meeting of the multi-central group where all the Moscow Berlin representatives will be there. There would be an update done. We will give all our recommendations to develop this protocol. We try to intensify the chemotherapy for the last few years. And now we can see that there cannot be further intensification done. But thanks God, now it's a new immunotherapy. Certain transportation technologies are in place based on the other mechanism of activity, based on the point targeted effect only causes tumor, neoplastic tumor. Currently, we can conduct this therapy, and one of the first options is to use the non-specific monoclonal antibody blinatumomab, which we used in patients with relapses, and we received twice twofold survival rate of the patients. And after this, we developed a pilot protocol based on which we tried to implement the blinatumomab therapy in the acute stage and implement it, and we wanted to reduce chemotherapeutic burden as well as the continuation of the treatment among these patients. So we created the design of protocol, and we saw this slide. From our point of view, we received revolutionary results. There is no lethality, zero lethality at any stage of our trial done. Non-toxic, non-infection complications. And relapse level was twofold less. It goes to the patients of the standard group. And now few slides about the acute myeloblastic leukosis lymphomas. Many colleagues, they know that this is a difficult disease. And they are sensitive to infectious diseases at the period of side effects. And 10 years ago, we lost the multi-center group, and the whole group should have to be gathered again. Currently, there are more 450 patients with the primary acute myeloid lymphomas. And within 52 clinics, we are conducting the trials on transplantation of the of stem cells. This slide shows the certification of the protocol. I will not stop on this. Intermediary results, they are quite impressive. It brings certain optimism, and we can see that within the group of the high risk, it could reach more than 60% of the survival rate, taking into account that this is a non-monocentric data of certain facility. This is a multicentric in research, and in perspective, we will implement the cell therapy to cities such as antigen as well as target antigen approach. Now a few slides about transplantation. When we start, in 2001, you can see in Russia, within a year, the transplantation rate was very low in comparison to other developed countries. We went through the big route journey, and you can see the amount of transplantation done annually. 2,600 transplantation were done in our center. When we start, there was different figures. There were not enough beds. Every patient had been waiting a queue. Certain patients were not reaching the transportation, but currently the queue is going fast, and within 2 or 3 months, all the patients they received the treatment needed. The strategy is to improve the situation, and that's why currently many patients they should be transplanted from the donors of the high risk group. That's why we need to develop certain transplantations. It was always difficult transplantation to do, which is connected to the high lethality case. Currently, result of the haploidentical transplantations is like that. Even though there are certain difficulties to find the donors, there are still no severe reactions with the transplant donor. Those are the final as well as intermediate results of haploidentical transplantation. Here you can see the overall survival rate in malignant leukosis, lymphomas is reached 65%. And if it's not malignant, then it reached 80%. The last thing that I want to talk about is the new technology of the CAR cell therapy. And it was also used in our center. We were using the vectors of our foreign friends. But in 2022, we had to start the technologies from scratch again. I cannot turn on the video, unfortunately. We created this technology at the level of our facility with the viral vector and cultivating this CAR cell lymphocytes. This is the general scheme. And of course, the first results were quite significant for us. You could see that we reached up to 60% of average survival. Those patients, they didn't have any therapy options before. We understood quite fast that in mono regime of this therapy is not working for everyone, and many patients they are still under the relapse, and maybe it is better to use it together with the transplantation of the bone marrow. That's why, as you can see on this slide, the patients who had transplantation of the hematopoietic stem cells, they have advantage in comparison to the others without transplantation. That's why currently we modify this strategy and we are conducting the transplantation simultaneously with the CAR cell therapy, and preliminary results are quite significant. Results are good. Out of 20 patients who received this therapy, 55% is the average survival rate. This is wonderful. I think the still development all over the world, as well as in our center, there are certain works on with T cell acute lymphoblastic leukosis, myeloid leukosis with different other leukosis. And CAR cell therapy is considered as a platform of immune therapy. It will go out from the framework of oncohematology, and it's oncology, it's a solid gliomas, and etc. This is a universal platform. I said that our directions are not limited. We are working on different protocols. We are always inviting for collaboration. We know that Uzbekistan is collaborating with our center. That's why we want to thank you. We are always ready to jointly participate in every project, and that's why I should say that our friendly team is doing a great job. And our smart authority, we want to thank them, as well as the support of the Ministry of Health of Russian Federation. And you know the President of Russian Federation as well, they are supporting us. Our mission is in that, so every child is happy from our work and healthy from our work. Thank you so much for your attention. I'm ready to respond to questions. Unfortunately, I know there is no time left. Are there any questions in reality? We want to thank you once more because this representation gave us a lot of information. There was information from Cleveland saying that there are more people who are sick, but their lethality is reducing, and your graphs are making us happy because this is a great work and results are following. Thanks you once more, and applauses for you. I want to thank moderators, and now it's a small lunchtime. Up to 15:00. Thank you.